We are starting session. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's live webinar organized by Academia of Global Obstetrics and Gynecology. As the name suggests, it's going to be a to Z series, and we have the second episode of this series, that is from birth and beyond. So I welcome you all. So now I take my pleasure inviting for the MOC of the today's session, Dr. Apurba Kumar sir. Sir is the National Coordinator of FOXY CME Workshop for Safe Abortion and Contraceptive CAFE 2020. National Coordinator in IGZO, FOXY, Adolescent Committee, Coordinator for FOXY, Sexual Medical Committee.
Stalin, thank you so much. Thank you so much. We are
So
already
welcome,
ready.
sir. I am handing session to you, sir. Please.
Okay. Are you going to show the video? No? Okay. So good evening to and welcome to all and one. My dear friend, it's give me an immense pleasure to invite you this wonderful webinar known as Academia Global Obstetrics and Gynae A to Z series. Today, we are the B series, that is the second series of this, which is, of course, the brainchild of the power couple of Foxy, that is our own very respected Dr. Niranjan Chavan and our very Hati so they need any introduction, but still Komal Chavan ma'am, can I have the CV? Just immediate past chairperson of the medical disorder committee FOXY. Ma'am is the medical director of Chavan maternity and nursing home, honorary professor RN Cooper Hospitals, Hospital and Medical College, and the zonal coordinator of the FOXY chairpersons, AMOG Family Welfare and MTP Committee, and member of the Managing Council of AMOGs, Joint Secretary of ISOPAP, Mumbai chapter, and whatnot. It's give me really a pleasure to invite and welcome you, ma'am. Thank you so much, ma'am. The next, Dr. Niranjan Chavan, sir. Sir is again at present the professor and unit head at the Sion Hospital, Mumbai. Sir is the joint treasurer of the FOXY 2021 to 24, at present president of Mumbai Society, member of the Oncology Committee of the CEFOG, joint secretary of Association of the Fellow Gynecologists, dean of AGOG and AG.
Thank you, Apurba. Thank you so much.
Thank you so much, sir, for always being there. Thank you so much. So I would like to hand over to Dr. Komal ma'am for the further proceeding.
Thank you so much, Dr. Apurva. And I welcome you all for this second series of Trending Ask the Expert series. And this is the series B. And when we obstetricians think about B, it stands for birth. And we know that birth is something which is really the most important part which we obstetricians play a role on. So birth is an experience that demonstrates that life is not merely function and utility, but form and beauty. And birth is as safe as life gets. And we really strive best to make the birth a beautiful and the most memorable experience for our patients. And so today's episode is going to focus on birth and beyond. So we are going to discuss things which are related to birth and things which are even later they come into the life of women. So today's series will include a birth and beyond, that is the birth injuries, to make the baby safe in both the mother and the fetus, everything safe and have a good outcome. Then it will focus on a very important part of the pregnancy, that is the 4th trimester, and later on also the benign adnexal masses, because so many times all masses are not malignant, and we come across so many times benign masses and we have a dilemma related to management, and that will be the case-based discussion. So I thank all the eminent faculties who have accepted the invitation and joined today. We have our chief guest, Dr. P K Shah, Dr. Guest of Honor, Dr. Rishma Pai, and we have our 2 speakers, Dr. Murlidhar Pai and Dr. Madhuri Patel, and our chairpersons, Dr. Ranjana Khanna, Dr. Vinita Singh, Dr. Veera Lohia, Dr. Suyoga Panat. They are really there through all the sessions. and we are going to have a power-packed panel discussion with all the eminent panelists who are going to throw light on so many aspects of benign adnexal mass. We have Dr. Vidya Thobbi, Dr. Manonmani, Dr. Arun Barua, Dr. Nivedita Dutta, Dr. Darshan Wadekar, Dr. Rajesh Darade, Dr. Shail Kaur, and Dr. Susheela Gupta. So we are really awaiting for a great scientific feast. And I think there was some little technical glitch in joining, and I'm just waiting for Dr. Rishma Pai and Dr. P K Shah to join so that we can begin with the chief guest and guest address. So let us have an inauguration video played, and then we can start the first session, because scientific session is the knowledge, that is Saraswati, is the best way to start a session. So we start with a scientific session. So let's have the lamp lighting video, and then we can go ahead and start the scientific session.
Kurutvam kalyanam arogyam dhanasampadam shubham kurutvam kalyanam arogyam dhanasampadam shatru buddhi vinashaya deepajyotirnamostute deepajyotirnamostute shubham kurutvam kalyanam arogyam dhanasampadam Shubham kurutvam kalyanam arogyam dhanasampadam.
Before we move on, I would like to request Dr. Niranjan Chavan to speak few words, and we can start the scientific session.
Yeah, thank you so much, Dr. Komal, and I'm really impressed with the amount of efforts which you have done, and I congratulate Dr. Apurba for coordinating this episode number 2, that is episode B, Birth and Beyond. So we have luminaries from obstetric and gynecology, and a wonderful lecture by Dr. Murlidhar Pai. Thereafter, the moderation of the program, that is for benign adnexal mass. And I would thank each and every one of you who have participated in this program. And I would like to thank Dr. P K Shah, sir, my mentor and my unit head and professor at Sion Hospital. Of course, that's where I am working still, and sir has been guiding us in Foxy, in IAG, in MOGS, and he has been also in the FIGO committee of Safe Motherhood. I'm expecting him to join very soon. As soon as he joins, then we will break for the inauguration. And my dear friend, Dr. Rishma Pai, who is going to join us soon. Thank you. With this words, I would like to hand over the mic to Apurba. Thank you so much.
Thank you so much, sir, for your kind words. And so we start our scientific session for today. And for the first session, I would like to invite the chairperson, Dr. Ranjana Khanna, ma'am. Ma'am doesn't need any introduction. Ma'am is the National Vice President, Foxy 2017. Ma'am is the Senior Consultant Director at Ranjana Hospital, Prayagraj. Founder President of Prayagraj, ISOPAP, the ICOG Governing Council Member 2021 to 23, President, Secretary, Treasurer of Allahabad or Prayagraj Yogi Society, organizing chairperson of many national conferences, and we enjoyed these a lot, ma'am, under your leadership. So thank you so much, ma'am. Ma'am has a lot of word in her credit. So thank you so much, ma'am, for accepting our invitation to chair the session. Our next chairperson is Dr. Vinita Singh, ma'am. Again, a very dear senior of mine. Ma'am is the Associate Professor, Department of Obs and Gynae at NMCH Patna. Ma'am is the president at present in the Patna Obstetric and Gynae Society. Ma'am is the past chairperson of Young Talent Promotion Committee, chair Foxy, and a lot of posts held by ma'am. Thank you so much, ma'am, for accepting our invitation to be one of the chairperson for the talk. So I would like to invite Dr. Ranjana Khanna, ma'am, to invite our first speaker, that is Dr. Murlidhar Pai sir. Pai sir is a wonderful orator, and I am really, sir, I am a great fan of your talks and your teaching. So over to you, Ranjana ma'am, to invite our first speaker.
Good evening, everyone. Thank you, Komal, for the invite. And it is always a pleasure. I keep on inviting Dr. Murlidhar Pai for my webinars. And it's a pleasure to introduce him. Though he actually needs no introduction, he is a wonderful orator to begin with. And as I was saying in my previous, the previous webinar of ISOPA Prayagraj, I just introduced Murlidhar Pai, and I said that when he is speaking, his talk, his lecture is almost like a flute recital. So it justifies his name, Murlidhar Pai. He is the Dean of Sikkim Manipal Institute of Medical Science in Sikkim. And he is a professor of Obs and Gynae, Sikkim Manipal Institute of Medical Science. He's got a lot of guest lectures, and he's been professor in HOD, OBGYN, KMC Manipal, professor in HOD, OBGYN, MMMC Malaysia. And he's got so many years of teaching experience, and we all look forward to hearing from you, Dr. Pai. And now I would love to hear the topic of birth injuries. So over to you, Dr. Pai.
Yeah, I would like to thank Dr. Komal and Niranjan.
I would like to add here, he is a versatile singer.
Yeah. Oh, wonderful.
Yeah, of course. I'm interrupting. I'm really sorry, madam. But he is a very.
I agree with you, Niranjan. I agree with you wholeheartedly. In fact, in some of our webinars, we motivate him to sing also.
Yeah. So thank you very much, Dr. Ranjana ma'am. Yeah, thank you again, Komal and Niranjan, who are my very good friends. And this topic is actually a slightly dry topic. I hope I can do justice for this topic. It is sometimes depressing, but there are very bright, side of it. Anyway, let's see. It's a tragedy that the baby, after going comfortably through 9 months without any congenital anomalies, everything, at the time of labor or at the time of delivery as such, the baby has to undergo some injuries or insults, maybe in the first stage, second stage, and at the time of delivery itself. So let us see what are these possible injuries. When we understand what are the possible injuries and what are the high-risk factors, probably we can prevent those injuries, and we should also know, in case such injuries happen, how to treat them. So that is the focus of my talk today. So by definition, birth injury is an impairment of the neonate's body function or structure due to an adverse event that occurred at birth. So it's not only the structural injury that can happen to the baby, but also because of maybe neuronal injury inside the brain, there can be a functional impairment as well. Both come under birth injury. That's what we have to understand. It's not just the physical injury that we can see obviously, but also a functional impairment we should consider. Injury may occur during labor. That's what I said. It is not always at the time of delivery. A prolonged hypoxia during first stage of labor, which was missed, and baby went into, let's say, late deceleration, and then for a late cesarean section, the damage has already been done, hypoxic damage of the intracranial structures. That also will impair the baby's or neonate's functioning. So obviously the second one is at the time of delivery, because of the delayed deliveries. Maybe there is a shoulder dystocia, maybe there is a prolonged, occipito-transverse arrest, or there may be a vacuum or forceps delivery, or both. After the delivery also, sometimes, inadvertently there can be injuries to the baby after the baby has been successfully delivered. Maybe sometimes the baby may slip from your hands, or sometimes you may inadvertently have certain other injuries, especially in neonates who require in the delivery room. So all of them can be prevented, and we should focus on prevention of these things, because as I said earlier, it's very, very sad if the baby has to have this kind of an insult in the last few minutes of its intrauterine life, and it is about to come into this beautiful world. What are the spectrum? It ranges from minor and self-limited problems, for example, laceration or bruising, to severe injuries that may result in significant neonatal morbidity or even sometimes mortality. For example, spinal cord injuries. So there can be a mortality as well. What is the incidence? This is a recent article. The incidence is thankfully very less, 2 to 3%, but it can be 100% for the mother or the baby who has undergone that particular injury. So it is always, not the numbers, it is the individual case that is very important. Scalp injuries usually are 80% of the injuries, because that's the leading part in most of the deliveries. The scalp injuries are the commonest injuries that we can see. There may be a nick even at the time of cesarean section, the forceps marks, and the cephalomatomas due to vacuum deliveries and other things. So among the scalp injuries, laceration and bruising are the commonest, and other ones are major trauma, 20%. The major trauma are fortunately less, but 20% is quite high. Any disease which we usually say anything less than 10% is acceptable, but anything more than 10% is not acceptable. Clavicular fractures, brachial plexus injuries, these are all major injuries. Intracranial hemorrhage, hypoxic ischemic encephalopathy, and seizures. They have got a long-term effect or far-reaching effect on the baby. What are the risk factors in general? First, let me talk about in general, then I will go to the individual injuries and the risk factors for those particular injuries. So in general, the increased risk for birth injury can be either due to a fetus itself, for example, a big fetus, size of the fetus, or a preterm baby. Second one is its presentation. Obviously, the malpresentation is the commonest cause of injuries. By far, we know. The other risk factor is the mother. Again, maternal size. So if she is a very tiny mother with a contracted pelvis, or a large mother who would obviously have a large baby, and presence of pelvic anomalies, there may be scoliosis, or there may be pelvic problems in the mother itself that can give rise to injuries to the baby. Then, of course, iatrogenic, I would say, use of obstetrical instrumentation during delivery. While instrumentation sometimes is inevitable, we have to use it to help the baby and the mother. That itself can cause injuries to the baby and mother if you are not well trained, or if you don't apply it in an appropriate manner or with an appropriate indication. So risk factors that increase the chance of birth injuries are macrosomia. Usually macrosomia means weight more than 4 kgs in the Western countries. But in Indian scenario, we should be very careful in adopting this particular, let's say the standard, because sometimes we have seen babies more than 3.5 kg also going in for shoulder dystocia in Indian scenario with the shorter mothers. So you have to take a call on to define macrosomia anywhere after 3,500 grams, and definitely after 4 kg, even in Western standard, it is macrosomia. It's an interesting finding that between 4,000 and 4,500 grams, the chance of injury is twofold. Between 1,500 to 5 kg, it is 3 times more. I don't know why they are waiting to deliver them vaginally. Even if they are delivered abdominally, that is by cesarean section, the injuries are more. Whenever the baby is more than 5 kg, though it is very, very rare, you can see that the chance of injuries is 4.5 times greater. And when the infant is more than 1,500, the injury is almost like 7.7%. You saw the general incidence to 2 to 3%, but you can see here macrosomia alone doubles it almost, in fact, triples it, 7.7%. Maternal obesity, I told you, mother also has a role in the birth injuries. Whenever her BMI is more than 40 kg per meter square, it's very, very, huge BMI. The baby also will be bigger in such mothers. So maybe due to greater use of instrumentation or the increased risk of delivering a large for gestational age infant. So these are the increased risk factors. As far as abnormal fetal presentation goes, it's breech that is particularly at increased risk. Of course, even the transverse lie, because you may have to do a lot of manipulations even at cesarean delivery. That is, you have to put your hand inside, do internal pedalic version first, followed by breech extraction. Breech extraction is always risky. You may inadvertently fracture the femur, the humerus, the clavicles, or all of them, and even the abdominal blunt injuries. Operative vaginal delivery. Both forceps and vacuum delivery are associated with an increase in the birth injury. We have seen a whole lot of injuries, which I'm going to elaborate later, which are due to forceps and vacuum. But that should not deter an obstetrician against using them. We must develop the skill and we should use it in an appropriate manner, then it can be safer. The sequential use. What do you mean by sequential use? If the forceps fails, you use vacuum, or vice versa. If vacuum fails, you forceps. It's a big no. In the beginning, I would like to say you should never ever use sequential use. But sometimes what happens, the prestige or ego comes in the way. You would have promised that I will give a vaginal delivery, hook or crook, and you want to avoid a cesarean section. You have already failed with one of the instruments, that is, let's say, vacuum. Then you would take the patient to the theater, but there you are tempted. Let me just try one more time with forceps. That is the biggest mistake you can ever do, both for the baby, mother, and yourself, and vice versa as well. So because this increases the risk of birth injury more than the use of either of the instruments alone. Other factors: increased incidence of birth trauma to the head and neck in male infants. I mean, this is debatable, maybe because of the size, and babies born to primigravida, this may be because of the pelvis, and this is not a well-tested pelvis. Small maternal stature, as I said, again, giving rise to contracted pelvis, and the presence of maternal pelvic anomalies are associated with increased risk. These come under the other risk factors. Now, what is there something called decreased risk for birth injury? Yes, this particular slide talks about that. It is unclear whether cesarean delivery is protective, because as I said earlier, even in cesarean section, it doesn't mean that you are totally avoiding injuries. Inadvertent nicks on the baby's scalp. This is the commonest injury that we see. And even at the time of delivery of transverse lie, just now I was explaining, you have to rotate the baby inside the uterus, and then you have to forcibly bring out the baby. Even breech delivery in during a cesarean section is going to be a little difficult, as may not be as difficult as vaginal delivery, but it is difficult. It's not easy. Healthcare cost and utilization project nationwide inpatient samples showed, this is from America, obviously, nationwide means American, cesarean delivery was associated with a decreased likelihood of all births trauma compared with vaginal delivery. Adjusted odds ratio is 0.55. So that much lesser to vaginal delivery. However, whenever you find one particular article there will be an exactly opposite article in the literature. So the other article says, that's why I put a question mark here, whether it is decreased risk at all. When the analysis used the definition of birth trauma developed by AHRQ-PSI, that is Agency for Healthcare Research and Quality Patient Safety Indicator, cesarean delivery was associated with the increased risk of birth trauma. I'm repeating, increased risk of birth trauma. Adjusted odds ratio is 1.65. That is more than the vaginal delivery. So why was the difference in these two slides? One slide says it is less, another slide says it is more. It obviously depends upon the definition of the birth injury. The AHRQ-PSI definition did not include clavicular fractures or injuries to the brachial plexus and scalp, which were more frequently seen in vaginal delivery. So if you exclude them, then obviously, the injuries, the incidence, everything will differ. So these findings suggest that risk varies between cesarean and vaginal delivery depending upon the type of birth injury. So if you include all the injuries, then the incidence will be different. If you exclude certain, then the difference will be there. Now I come to one by one injuries. First, let us consider the soft tissue injuries. The most common form of traumatic birth injuries are soft injuries, including bruising, petechiae, subcutaneous fat necrosis, and lacerations. What is bruising and petechiae? Usually, they are self-limiting and are often seen on presenting portion. That is, maybe in a genitalia in case of the breech deliveries, bruising and edema are common. Head and neck, petechiae of the head and face are often seen in vertex and face presentation, obviously. Most often, petechiae are present at the birth in these kind of situations if it is due to injury, and they do not progress and are not associated with other bleeding, which means that the baby doesn't have any bleeding disorder. It is purely due to birth injury. However, you need to do a platelet count to rule out thrombocytopenia if petechiae persist or continue to happen, or if there is other bleeding that is present in the baby, in other than the presenting portion. I hope it's very clear to us now. Significant bruising has been recognized as a risk factor for the development of early and or severe hyperbilirubinemia. If it's a small bruise, it's okay. Small petechiae, it's okay. But if they're big hemorrhage, then there can be hyperbilirubinemia. Close follow-up after newborn hospital discharge is recommended in such patients, because these are the patients may have a prolonged jaundice. Then subcutaneous fat necrosis. It is uncommon, thankfully, and usually occurs in the first few weeks of life as a result of ischemia to the adipose tissue, often adjacent to the bony structure following a traumatic delivery. Maybe you use some instruments, maybe you used force to bring out a leg or something like that. It's actually a blunt injury almost to the fat, we can say, or it is caused by ischemia. So it is something like a necrosis due to ischemia. It is characterized by firm indurated nodules and plaques on the back, buttocks, maybe when you are trying to rotate the baby with the femoropelvic grip in order to make the back facing you, thighs, forearms, and cheeks. Nodules and plaques may be erythematous, flesh-colored, or blue-colored. Typically, this condition is self-limiting, with resolution usually occurring in 6 to 8 weeks of age. So you have to have patience. You have to counsel properly the mother. That is, it will resolve on its own, may take 2 months up to. These infants require long-term follow-up for the development of hypercalcemia, which can occur up to 6 months after the initial presentation of the skin lesions. So this knowledge is very important to counsel the patient. Now I come to the lacerations. Most common injury associated with cesarean delivery. As I was just telling, don't think that cesarean deliveries are going to avoid birth injuries. Laceration is the common injury associated with cesarean delivery. In a study of 3,108 cesarean deliveries, laceration rate was approximately 3%. 78% of the 3% happened when you did an emergency cesarean delivery. Most often on the presenting part, typically the scalp and face, obviously a nick here and there in a hurry. Majority were mild, luckily, requiring repair with steri strips only. You just put a plaster there. However, 3 out of 97, that is 3% of the 3%, I mean, very, very small numbers, were moderate or severe, located on the face or ocular area, and required plastic surgery for repair. That's very tragic. Now I come to extracranial injuries. After the soft injuries, which are lacerations, bruises, I come to now the extracranial injuries. The commonest, what we all know, is the caput succedaneum. Now, it is an edematous swelling of the scalp above the periosteum. This is very, very important. That's why I put a color coding green color above the periosteum, which is occasionally hemorrhagic. Occasionally, it's mostly edema. It presents at birth after prolonged engagement, maybe a delayed second stage due to occipito-posterior and things like that, of the fetal head in the birth canal, or after vacuum extraction. Now, vacuum is a chignon which is artificially created. It's basically the edema there. It's not an injury as such, right? So that maybe also look like a caput succedaneum. Unlike cephalhematomas, which is definitely a hemorrhage there, it extends across the suture lines. This is very, very important to differentiate between cephalhematoma and caput. It extends across the suture lines. Generally a benign condition, and it usually resolves within a few days and requires no treatment. This is the most important thing we need to understand, to know the difference between caput succedaneum and cephalhematoma, because caput succedaneum resolves on its own and does not require any treatment. So diagnosis is very important here. It extends across the suture lines. Now, caput succedaneum may be complicated sometimes with necrotic lesions resulting in long-term scarring and alopecia. Halo scalp ring is an annular alopecic ring that occurs in infants after a prolonged or difficult labor due to compression from bony prominence of maternal pelvis. I told you maternal pelvis is the third risk factor for all the birth injuries, other than mother herself and the neonate and iatrogenic. Rarely, systemic infection may occur as a complication of an infected caput succedaneum. We should not allow it to go that far. Now I come to cephalhematoma. Cephalhematoma is totally different. As you can see here, it's a subperiosteal. I'm putting the color red here. Earlier, I put the green color. It is above the periosteal. It is subperiosteal collection of blood caused by rupture of vessels. It's not just edema. It's a rupture of vessel beneath the periosteum, usually over the parietal or occipital bone, which presents as a swelling that does not cross suture lines. So these two things are very important. One is above the periosteum, and it does cross all the suture lines. That is the caput. Here it is below the periosteum and it does not cross the suture lines. So just physical examination or inspection should give you the diagnosis. The swelling may or may not be accompanied by discoloration, rarely expands after delivery, and does not generally cause significant blood loss. Whatever has happened has happened. Estimated to occur in 1 to 2% of all deliveries and is much more common in forceps and vacuum deliveries. This is very, very important for us to understand. Ultrasound is useful for characterization of fluid collection. However, it may not clearly depict the location of the hematoma related to the skull fractures. So CT MRI is better. It will confirm the location and also be useful for evaluating the presence or absence of associated osteomyelitis. We do not routinely do CT MRI. As I said in the previous slide, physical examination is more than enough. But sometimes if it goes into osteomyelitis, abscess, and things like that, you may need this. Cephalometoma is a risk factor for the development of early and/or severe hyperbilirubinemia, obviously, because there's a lot of blood clot there, and that will give rise to bilirubin, and it has to be clear. Close follow-up after the newborn hospital discharge is recommended in order to assess the jaundice. The majority will resolve spontaneously. Even cephalometoma will resolve on its own, like caput, over a course of few weeks without any intervention. It may take a little longer than the caput, but it will resolve on its own. But there can be calcification of hematoma in some cases, subsequent bony swelling also that could persist for months. Significant deformities of the skull may occur when calcification or ossification of the cephalometoma occurs, and that can give rise to other complications that include infection, osteomyelitis requiring incision and drainage, and even use of systemic antibiotics. Now I come to extracranial injuries in terms of hemorrhage. First is subgleal hemorrhage. Subgleal hemorrhage develops when the blood accumulates in the loose areolar tissue in the space between the periosteum of the skull and the aponeurosis. This is slightly different from the cephalometoma, what I was explaining earlier. The injury occurs when the emissary veins between the scalp and the dural sinuses are sheared or severed as a result of traction on the scalp during delivery. That typically happens when you do a vacuum delivery. The subgleal hemorrhage occurs 4 of 1,000 spontaneous vaginal deliveries, whereas 59 out of 10,000 vacuum-assisted deliveries. You can see the difference, 4 versus 59. Potential for massive blood loss into subgleal space contributes to high mortality rate associated with this lesion. With cephalometoma, hardly any babies die. I have not seen any baby die with cephalometoma as such, but with glial hemorrhage, there can be massive blood loss because the subgleal space extends right from orbital ridges anteriorly to the nape of the neck posteriorly and to the level of ears laterally. So much of blood can be collected in this area, and that almost like baby bleeds in itself to death. In infants with subgleal hemorrhage, the reported mortality is approximately 12 to 14%. It's very high. It's very, very high. Okay, after the extracranial injuries, I come to the face injuries before I go into the intracranial region. Face injuries can be nasal septal dislocation. Such a beautiful nose can be distorted. It occurs in 0.6 to 0.9% of deliveries, very, very low, luckily, due to compression of the nose from symphysis pubis or sacral promontory. So that is why maternal pelvis is very, very important factor in the birth injuries. Infants with significant trauma can represent with respiratory distress due to airway obstruction, so much so the nasal dislocation can happen. The diagnosis is made by rhinoscopy and manual reduction by otolaryngologist using a nasal elevator should be performed by 3 days of age. Otherwise, baby will have probably permanent dislocation. No treatment or delay in treatment may result in nasal septal deformity, which may later require a major surgery. Ocular injuries, they also come under the facial injuries. Minor ocular injuries or trauma such as retinal or subconjunctival hemorrhage and lid edema are common, and they usually resolve spontaneously without affecting the infant in 1 to 2 weeks. This is okay. But if you have significant ocular injuries, luckily they are less. We had one such, which again spontaneously resolved in Manipal long ago, and the blame was on the vacuum extraction. Baby recovered the site within 3 months. Associated with forceps delivery include hyphema, that is blood in the anterior chamber, vitreous hemorrhage, orbital fracture, lacrimal duct or gland injury, and disruption of the Descemet's membrane of the cornea, and need prompt ophthalmic consultation. Well, now I come to the very grave injuries, that is intracranial hemorrhage. This includes subdural, subarachnoid, epidural, intraventricular, and intracerebral and intracerebellar hemorrhages. Intracerebral hemorrhage is almost detrimental, and the baby can die. The risk of intracranial hemorrhage increases with the operative delivery straight away. 3.7 per 10,000 in unassisted to 16.2 in vacuum assisted to 17 per 10,000 in forceps assisted deliveries. As you can see here, almost 5 times more in the forceps and vacuum deliveries. This may be an underestimation against 26% in spontaneous vaginal birth as per the study that used MRI screening. That means even in spontaneous deliveries, there is a chance, 26% chance of intracranial hemorrhage as per this second study, which means with the guidelines that the study used MRI screening, the problem with vacuum and forceps must be much more. Subdural hemorrhage, although incidence is rare, it is the most common type of intracranial hemorrhage. Location is between obviously dura mater and arachnoid membrane. Risk factors are higher among vacuum and cesarean and forceps. The presentation is seizure, respiratory depression, apnea, neurologic dysfunction in the baby. Imaging, of course, CT is always better and quick, but you can also do MRI if you have a lot of time. Management depends upon the location and extent of the bleed. Most cases can be managed with conservative therapy without surgical intervention in subdural. Surgical evacuation is necessary with signs increased intracranial pressure, only if it is there. SDH that occurs in the posterior fossa may cause brainstem compression because, as you know, there is no scope for expansion in posterior fossa. Whereas if it is anterior or upper, then there is the sutures are not ossified, so there is expansion scope. That's why if it happens in the posterior fossa, there can be brainstem compression that requires emergent surgical evacuation, otherwise not required. Seizure disorders should be treated with anti-seizure medications, and that may go for a long term, 2 to 3 years. Now I come to subarachnoid hemorrhage. This represents the second most commonly detected neonatal intracranial hemorrhage, most often caused by rupture of bridging veins. Although subarachnoid hemorrhage occurs with normal spontaneous vaginal deliveries, risk obviously increases, as you can see there, with forceps and vacuum. As with subdural hemorrhage, newborns with subarachnoid hemorrhage most often present 24 to 48 hours life with apnea, respiratory depression, and seizures. And diagnosis is best done by CT. Conservative management is most often useful. Rarely, a large subarachnoid hemorrhage can cause post-hemorrhagic hydrocephalus, and that has to be dealt accordingly. Epidural hemorrhage is very, very rare, usually because of the middle meningeal artery rupture. The rarity of the neonatal epidural hemorrhage is attributed to the absence of middle meningeal artery very nicely being protected. And EDH is often accompanied by linear skulls fractures, often associated with operative deliveries. It is common for all. Operative delivery is the commonest, it's the culprit. EDH and cephalohematoma can coexist when accompanied by an underlying skull fracture due to communication through the skull fracture. So present with non-specific neurological symptoms such as seizures, that's a common. The diagnosis is by CT again. Supportive therapy is good enough. Very rarely you need to evacuate them. Now I come to the most grievous, that is intraventricular hemorrhage. Now, although it is usually associated with preterm delivery, IVH is also reported as a consequence of birth injury in term infants up to 4%. The risk of IVH increases with, again, operative deliveries. As you can see, the numbers keep on increasing as the operative delivery increases. 1 is to almost 3 or 4. In the absence of a clotting disorder, it should resolve spontaneously and should not have any long-term sequelae. However, for infants with IVH due to significant birth trauma, close monitoring is definitely required due to the risk of extension of hemorrhage, number 1, into the surrounding parenchyma, and the development of post-hemorrhagic hydrocephalus. So you cannot just leave them alone. Then a totally different kind of injuries, that is fractures. Clavicular fracture being the most common, and risk factors: operative delivery, shoulder dystocia, intracranial. Sometimes in shoulder dystocia, you do a deliberate, purposeful clavicular fracture in order to deliver the baby. Desperate. Presentation is depends upon whether it is completely dislocated or not. You can hear just a crepitus and lack of movement. In a non-displaced one, it is usually lesser. Diagnosis is by radiograph, and management is usually reassurance because it will heal on its own. Nothing much have to be done. Maybe analgesic if the baby is all the time crying. For comfort's sake, you can place a long-sleeved garment which is pinned to the chest. Humerus fracture, most common long bone fracture compared to the femur, though it is less, 0.2 per thousand, but it's the commonest one. Risk factors, again, shoulder dystocia, macrosomia, cesarean delivery. Presentation is again, the movement is restricted, baby starts crying whenever you touch that area or move it. Diagnosis is, of course, by X-ray. Again, treatment is immobilization of the affected arm. Usually, in the small children, all these fractures, they will heal very nicely. Maybe you have to just immobilize them. Nothing much to worry unless big hemorrhage has occurred there. I am not going to go with the femur and the skull fractures for want of time. Skull fractures, very rarely they require any treatment. Femur fractures are again dealt the same way as humerus fractures. I'll conclude my talk with the neurological and abdominal injuries. Neurologic injuries can be brachial flex injury, usually seen in case of, again, shoulder dystocia if you desperately pull the head, or even in case of breech delivery if you are trying to deliver the aftercoming head in a pulling manner. Phrenic nerve injuries often associated with brachial plexus injuries. Clinical manifestations include respiratory distress because phrenic nerve is involved here. Facial nerve injuries occurs in 0.1 to 7% due to compression of the nerve by forceps or prominent maternal sacral promontory. Usually it is forceps. Laryngeal nerve injury during birth may cause vocal cord paralysis. They cannot sing, these babies, unfortunately, maybe. Symptoms include stridor, respiratory distress, hoarse, faint, absent dysphagia. Neurologic injuries continued. Spinal cord injuries are rare, luckily, with an incidence of 0.14 to 14 per 10,000 live births. They occur more frequently in the upper cervical spine rather than lower, especially when you are trying to deliver by maybe burn Marshall technique and desperately trying to deliver the neck in case of shoulder dystocia. Injuries include spinal epidural hematoma, vertebral artery injuries, traumatic cervical hematomelia, spinal artery occlusion, and transection of the cords. Most of these nerve injuries, you can't do much. They will probably resolve on their own given time, and maybe all that you need is physiotherapy a little later. Risk factors include forceps delivery, again, for the spinal cord injuries. Now I come to the last part of the injuries, that is abdominal injuries. And these injuries usually are intra-abdominal birth trauma, uncommon, and primarily consists of rupture of subcapsular hemorrhage into the liver, spleen, and adrenal glands. Presentation depends upon the amount of blood loss, obviously. Infants with hepatic and splenic rupture may present with sudden pallor, signs of hemorrhagic shock, and abdominal distension and discoloration. Very easy to diagnose on physical examination. Whereas infants with subcapsular hematoma may have a delayed or more insidious onset of symptoms of anemia, which include poor feeding, tachycardia, and tachypnea. Maybe ultrasound is required in these patients. Unilateral adrenal hemorrhage may present as an abdominal mass, should be kept in mind as a rarity. What are the risk factors for abdominal injuries? Obviously, macrosomic babies and breech delivery, especially if you try to hold the abdomen and rotate the baby. It should be always femoro-pelvic grip. And in macrosomia, even at cesarean delivery, you may hold the abdomen and deliver. If your nails are a little longer, then it may cause injuries. And the use of instrumentation during delivery. Ultrasonography is the best modality to diagnose, as I told you already, but sometimes you may require CT as MRI as well. The management includes fluid resuscitation with blood products and normal saline as appropriate. Fresh frozen plasma may be needed to correct any coagulopathy associated with injury, because once the bleeding is more, they go into coagulopathy. In infants with hepatic or splenic rupture or who are hemodynamically unstable, laparotomy may be required to control the bleeding. That's the last resort. Thank you very much for your patient listening. I have tried to cover as many injuries as possible and given you a perspective.
Yeah, thank you, Dr. Pai. That was a wonderful talk. In fact, actually, the topic is so vast. But one thing I wanted to say is that no doubt birth injuries are very, very depressing. And the major cause is instrumental delivery. And of course, a misdiagnosed mild CPD can often be responsible. So we keep on and on trying for the baby to deliver, and that results in all the, caput succedaneum and all. But I've seen that it is not the instrument that you can blame. Sometimes it is the operator who is responsible because you have not rightly diagnosed whether the head is rotated or not. If you are not diagnosing the anterior and the posterior fontanelle because of edema, then don't blame the forceps. Blame the applicator, the person who is applying the forceps. Because if there's if you apply one blade here and one blade there, obviously the baby is going to have ICH. So you have to be very careful in the choice, and the operator, I think, the obstetrician has to be very good to decide that in this case, whether it should be an instrumental delivery or it has to be a cesarean. And I'm of the belief that ever since we are doing more frequently cesareans, the rate of birth injuries has come down. And regarding the injury, the lacerations and the incisions, I think that is, because
Exactly.
of the, fault of the surgeon.
No. But anyway, that is a minor injury which is very easier to tackle than getting into a major injury during vaginal delivery.
Yeah, because we've never done it. I mean, luckily, we've never done that. So another thing I was wanting to point out is precipitate labor. Because sometimes in precipitate labor, in 2-3 pains, the patient is unaware, she's standing and the baby plonks out.
Correct.
And that happens in very roomy pelvis. So when the baby falls down, then there's a rupture of the cord, the baby suffers a skull fracture. So these things have to be also considered. So if by chance there is a history of precipitate labor in the first baby, please be very careful in the subsequent one, because you have to be sure that the patient is hospitalized, admit the patient, you can try to slow down the pains also. So thank you so much, Dr. Pai. And it was a lovely topic and of course, extremely well delivered by you.
Thank you.
Thank you.
Thank you so much. Before we move further, we have our guest of honor and our chief guest with us. So may I request Komal ma'am to please introduce very respected Dr. P K Shah sir and very dear Dr. Rishma Pai ma'am.
I'm so honored that I have presence of our chief guest, Dr. P K Shah, and our guest of honor, Dr. Rishma Pai. I welcome them both. We all know Dr. P K Shah is a very eminent teacher of teachers. He has been my teacher. He has been the professor and the head of the unit at, say, GS Medical College and also at the Sion Hospital. Past dean of ICMU, past president of IAG, FOXY, IFUMB, and MOGS. Also the past vice president of SMTA Sion Hospital, past chairperson of the Imaging Science Committee of FOXY. He is a great orator. He is a legend in himself. He's an icon, and he has really been a great teacher. The teachings which he has given has the way I have carried forward myself all my career. So I'm very honored that Dr. P K Shah sir is here, and I would request sir to address the gathering.
P K Shah sir? Yeah. Sir, please unmute yourself. Previously you are unmuted, but again you are muted. Sir, please unmute yourself. P K Shah sir.
Sir, you are muted. You are muted still.
I request the admin, yeah.
Hello.
Yeah, admin.
No, it's all right now. It's all right.
Hello.
Yes, sir. Yes, sir, you are audible.
Can you hear me?
Yes, sir. Yes, sir.
Yes,
You are
sir.
audible.
Yes, sir, you are audible.
We can hear you, sir.
Start talking.
I can't hear the voice.
Sir, we can hear
We can
you.
hear.
We
Sir,
can
we
hear.
can hear you. We
Huh?
can hear you.
We can
We
hear
can
you,
hear.
sir.
Okay. So
Somebody
thank you
type,
very
yeah,
much for
somebody
having
should
me in this webinar.
Yeah.
Dr. Komal, Dr. Niranjan, and
Yes,
Dr.
sir.
Apurba Kumar Dutta. Sorry, there was a big problem joining this webinar. Ultimately, I could join. Now,
Thank you.
it is something great to see that Dr. Murlidhar Pai has already finished one talk, which was excellent. And now Dr. Madhuri Patel is going to talk on breastfeeding, the fourth stage, something very interesting. And this is going to be followed by a panel discussion, which is again on adnexal mass by Dr. Komal and Dr. Niranjan. It gives me great pleasure that you have a varied subjects going to be discussed today. And I wish Komal all the very best for all her future endeavors. She has been an excellent worker, hard worker in Foxy, and I wish her all the very best for whatever she does in future. Thank you very much for having me, because I have to join one more webinar and deliver a talk. So I shall take your leave. Thank you very much.
Thank you.
Thank
Thank you
you.
so much, sir,
Thank you,
for
sir,
your
for yes, sir.
honor and
Sir, and we
blessing.
look forward to see you at the MOGS Gold 51st Annual Conference. We will look forward to see you, sir, this weekend. I think sir can't hear. Thank you.
Yes.
Thank you, sir.
Yeah. Thank you, sir. And now I take pleasure to introduce our guest of honor, Dr. Rishma Pai. Who doesn't know Rishma Pai? I think she is the diva, the style icon, the legend, and really, we are really inspired by her in every aspect of life. You know, she has been the past president of MOGS, SR, IAG, Foxy, and the immense work she has done as Foxy president, it is so commendable. She is currently the consultant gynecologist at Lilavati Jaslok Hinduja Care Hospital. She's also received the honorary fellowship, Adam, at the Royal College of Obstetrician and Gynecologist, London, most inspiring gynecologist of Western India award by the Times Group, recipient of the Women Empowerment Award by the IMA, recipient of Midday Health Wellness Award as icon in obstetrics and gynecology and infertility. You know, there are so many awards. There are almost 50, I think they are mentioned here, maybe hundreds of awards for doing so much immense work in women's healthcare. And I'm so honored that she is here. She has given 70 orations and has been invited speaker as 40 plus conferences. So over to you, Dr. Rishma Pai, to address the gathering.
Thank you. Thank you so much, Komal. Good evening. Almost an embarrassing introduction, and you are getting more and more floral in your language and more elaborate in your descriptions. So thank you so much for that. Like Dr. P K Shah said, it was a little difficult to join in, but the good thing that happened because of that was I got to listen to a very, very dear friend, somebody whom I really respect and look up to, and that's Dr. Murli Pai. And of course, I think I'm going to stop doing obstetrics after listening to his talk. It was so scary. But it's true that obstetrics is something which, is very, very, it fulfills us. It gives us a lot of a sense of happiness. And if we deliver somebody safely, the mother and child, is very, very rewarding. But if there is a complication, and you can see from his lecture how many of them can be there, it can be really traumatic, of course, for the family and for the obstetrician. So it's an eye-opener. And sometimes day to day, we don't think about all these things, but it's important to be reminded of how careful we have to be and how gentle we have to be with every single patient whom we deliver. So thank you, Dr. Murli Pai, for that. And of course, I think the next subject is going to be even more interesting with every my patients that, the pregnancy part was the easiest part. And now when they actually start the post-delivery breastfeeding segment, that is actually the most difficult because they really have a tough time adjusting to breastfeeding. So I think that will be extremely interesting as well. I really believe that, the intellectual growth and learning has to commence at birth and end only when we leave this world. So constantly we are, increasing our inputs, knowledge, wisdom. And it's really thanks to all these teachers who are here today, each one of them who's giving us such fantastic inputs and sharing their experience of many years, which works. So I think at the helm is Komal and Niranjan. I don't know how many academic activities they all are doing. It's phenomenal and you're working really hard. I congratulate you for that. And yes, Niranjan, looking forward to joining you and MOGS this weekend for the annual conference. Thank you so much for giving me this honor. All the best for the seminar and happy learning to all of you. Thank you. Thank you so much. Apurba. Fantastic job as always.
So much,
Thank you.
Thank you so much.
I'm really looking forward to hearing you.
Thank you, madam. Thank you so much
Thank you.
For those insightful and inspiring words. And thank you for joining in spite of all the glitches and everything. I'm really happy and honored. And I'm also awaiting to hear Dr. Madhuri Patel's talk. Welcome, madam. So over to you, Chairpersons.
After this wonderful first lecture by our own Dr. Murli sir, now it's the time to have the second lecture, very interesting, the breastfeeding, the fourth stage of labor. So by none other than but our own very dear Dr. Madhuri Patel ma'am. So chairing the session, we have a very dear seniors of our as a chairperson, Dr. Veera Lohia ma'am. Ma'am is the senior consultant director at the Janak Hospital. President of the Gwalior OB Society 2020 to 21, Secretary of All MP OBG from 2019-21, Executive Committee member of the IAG Committee 2020 to 22, Secretary of Gwalior Society, past president of IMA Gwalior, and past joint secretary of all MP OB Society, and a lot of credit in her CV. So thank you so much, ma'am, for accepting our invitation and to be part of this webinar. And second is Dr. Suyoga Panat, ma'am. Ma'am is the consultant gynecologist practicing in Amravati since last 12 years, recipient of late Tripti Umranikar Award for standing first in Pune University, recipient of late Srimati Salja Chaudhary Award in 2020, past secretary of Amravati OB Society, the past treasurer of the PRISM Conference, member of the Ethical Medico-Legal Committee of FOXI 2020-22, work in the PCPNT cell for 3 years, and a lot of awards in her credit. So thank you so much, ma'am, for being part of this webinar. Now over to Dr. Veera Lohia, ma'am, to introduce our, ma'am is there? Veera,
Yeah, I'm there.
To introduce our second speaker, Dr. Madhuri Patel, ma'am.
Thanks, Apurba. And I thank Dr. Komal also for giving me this opportunity. After brainstorming session of Dr. Murlidhar Pai, we invite our next speaker, Dr. Madhuri Patel, who is Secretary General of FOXI now at present, and she has been past Joint Secretary FOXI 2009, former member of FIGO, preterm birth. Then she has been clinical associate, Vidya Hospital, Parel, Mumbai, honorary consultant, Elizabeth and Marsha Hospital too. She has been awarded the MOX, Mrs. Shailja and Mr. Narayan Pandit Award 2019 and 20, associate editor of FOXI, and also winning book that is Gynec Cancer 2009, and she is going to speak on breast.
I think she's lost connection. We can welcome Madhuri madam to speak.
Yeah. Can I share my screen?
I missed
Yes, ma'am.
meeting you when you were there in Gwalior, Dr. Madhuri.
Yes, yes, yes.
I missed, sorry.
Yeah, yeah, no problem. Yeah. Respected chairpersons, Dr. Veera, Dr. Suyoga, our chief guest, Dr. P K Shah, our guest of honor, Dr. Rishma, our joint treasurer and MOGS president, Dr. Niranjan, and today's co-convener, Dr. Komal, convener of this program, Apurba, our master coordinator, MOC of this webinar, Dr. Murlidhar Pai, Dr. Ranjana, Dr. Vinita Singh, and all my dear friends, speakers, chairperson, and all the moderator and panelists. Very good evening to all of you. At the outset, I would like to thank Dr. Niranjan, Dr. Komal, and Dr. Apurba for giving me this opportunity. The topic actually is a breastfeeding, understanding the fourth trimester management. However, I will not concentrate on breastfeeding. I would like to talk all aspects of this fourth trimester management. So once you say what is fourth trimester, we have heard about first trimester, second trimester, third trimester, and we have heard about the PPRM. So what is fourth trimester? So it is the trimester after baby's birth, which can last for 3 months or which can last for many months. It is used to describe the many changes and development of newborn. And sometimes when you talk to the patient, when they say that many patients say the fourth trimester for them is very, very difficult, and very few women mothers will say it was very, very easy. So the term fourth trimester reflects the transition period that occurs from childhood and during the few first months of new parenthood. Newborn requires months of intense womb-like nurturing for optimal growth and development. Remember, when the fetus in womb, the mother has to take care of herself. That is in nutrition and all aspects. But when the baby is out, when the newborn is born, then only mother eating or taking care of herself is not enough. She has to take care of the baby, which is more than a womb care. The transition to motherhood necessitates the substantial transformation for women who are simultaneously experiencing unique and changing hormonal shift and expanding the roles and responsibilities. So here, the mother responsibility increases many, many folds. So if you look at this, the interrelated health domain in the fourth trimester, that she has to take infant care and feeding all the time. She may be on some medication or substance exposure. Then she has to recover physically as well as mentally from the childbirth. Then the sexuality also comes into it. So she has to have contraception and birth spacing, and her eating and sleep habits are totally disturbed, and ultimately she is fatigued. So the aim of the postpartum care is to assist and support women's recovery to pre-pregnant state and identify deviation from normal, educate the mother to take care of herself, her newborn, and breastfeed her child, advise contraception for mother, and promote bonding between newborn, not only with her, but entire family. So the ACOG committee opinion says the postpartum care should be an ongoing process rather than a single encounter. Contact either in person or by phone within first 3 weeks postpartum, followed by ongoing care, and concluding with a comprehensive visit by 12 weeks postpartum. So what are the components of postpartum care? That first 6 to 10 hours of postpartum, one has to look at the baby, whether the baby is breathing properly, whether the temperature is maintained, whether she is feeding properly, umbilical cord care, and immunization. As far as mother is concerned, blood loss you have to see, and accordingly you have to treat, because the postpartum hemorrhage is very, very common. She may be in pain, agony, her blood pressure, you have to take care if she was a case of PIH and otherwise also. And we have to wait for the warning signs, which only mother can say that what is happening, what is going wrong. Then 3 to 6 days postpartum, we have to look for the baby, whether the baby is taking feeding properly or not, whether there is infection, and routine tests can be carried out. And the mother, breast care, look for the fever, infection, Lohia, and her mood changes. 6 weeks postpartum, one has to weigh the baby, feeding is proper or not, and of course the immunization has to be done. The recovery, mother is concerned whether she has recovered completely, especially anemia. Previously in the past, we used to give hematinics for 1 month and then, continue the calcium for, throughout the, lactation. But now we have realized that the postpartum, 4th trimester is very important to recover from the anemia. And sometimes some, institute, they also, if the patient is anemic, they also like to give IV iron. And of course, contraception and libido. 6 months postpartum, we have to have a developmental, because the baby is now developing, and baby is not happy with only breastfeed, requires more and more food. So the homemade foods are the ideal. But if the mother is working, then we can recommend, the top food, and therefore, nowadays, the breast pumps are available. The mother can pump the breast milk and keep in the fridge on the room temperature 4 hours. There is no need to heat. But when you keep in the fridge, you have to, take care, and you have to warm only in the hot water and not on the gas. So these options are available postpartum. And secondly, it has been reported. There are many studies, they say if there is there is a support from the husband and the family and also at the workplace, this mother, once they join their work, they can breastfeed for a longer time. Of course, at home, mother who are housewife or working from home, they can breastfeed for 2 years also, provided in between, they give the homemade food. Then general health of the mother should be established properly. You have to advise contraception, and if there is morbidity, you have to take care of that. So there are 4 general categories: medical complication you have to take care, breastfeeding, mental health issue, and sexuality and contraception. Now I would like to say about the mental health issue that many of our women, mothers, nowadays they suffer from the postpartum depression, and we have to really take care of this depression part, because they get worried what will happen, because she is working, she has to do so much of work, and she is really worried that and she can go into postpartum depression. So the component of postpartum care, that patient can have a vaginal pain following episiotomy or following perineal tear, and it can take time to heal. It can get infected, so you can give them the painkiller, and if it is infected, you will have to start the antibiotic and other, like ice pack to relieve the pain, or you have to sit on the ring to be comfortable. Then patient can have vaginal bleeding. You have to be careful about the postpartum hemorrhage, whether she's in postpartum hemorrhage or not. Then breastfeeding, one has to learn from day one, because there are lactation consultant, or there are staff in charge of the lactational at the hospital. They give the counseling during antenatal period onwards. So the mother is well prepared for the breastfeeding. At the same time, as soon as the baby is born, one has to take care whether the baby, they are to be taught, the mothers are to be taught that there is a proper latching is there, baby is swallowing or not, what are the nipple types, whether it is retracted, then what you can do, and what are the condition of nipple, and how to hold the baby. These are also very important part during breastfeeding. As far as nutrition is concerned, the majority of the women, mother would like to come back to their, pre-pregnant, weight. But, many times it so happens they cannot come because they have excessive gain during the pregnancy, or some gestational diabetes patient, they are likely to not go back to the normal weight. And of course, the low socioeconomic status, black race are likely to retain their weight. So advise women to do the proper exercise, not immediately after cesarean, but with the consultant, how to start exercise, what to take nutrition, they have to take healthy food. In our Indian, scenario, we always give the healthy food like, laddus and ghee and all. So nowadays, all the women who are mother, they're educated and they know. So, but they have to have healthy food. The breast engorgement problem also experienced many women, because the child is not breast for a longer time, then they can have breast engorgement. And if child is fed, still the child is feeding from one side, then the other breast can get engorged and it can cause a breast abscess. So we have to be careful. You have to tell the mother to take out the milk from that side, other side, and feed the baby from the next feed from the breast which is engorged. Then one has also problem, the mother also have a problem with bladder and bowel function. Majority of the time, because of the episiotomy or with the cesarean section or with the perineal take, they try to avoid, passing urine, and then the bladder can be overfilled. Then majority of the time, women are constipation during pregnancy, and that can be continued, and after cesarean, it is more likely to be. So you can give laxative to them. And as far as sexual relation concerned, it has been reported there is a decrease in the libido because the estrogens are deficient, they have decreased. And when the mother is breastfeeding for the year, up to that time, the estrogen may be deficient. So there are chances of decrease in libido, and therefore she requires a proper reassurance. Contraception, yes, it is said that the breastfeeding is the best contraception, but no. ACOG recommends progesterone-only contraception are the best hormonal contraceptive modality for the breastfeeding women. The education is very important to this mother about the newborn baby care, such as umbilical cord care, bathing, breastfeeding, and importance of immunization. So you have to stress upon when you are doing counseling. And special care when the woman has an abortion, stillbirth, and neonatal death. I have seen in the hospital when such thing happens, many of the women undergo depression. So we have to be very, very careful. At the same time, we have to explain husband and the family to support such women when such mishap occurs. So the universal self-care needs sleeping and eating. So we tell the mother, you have to sleep and you have to eat when your baby is sleeping, and you have to adjust the timing. Then as we know in India that first pregnancy, usually it happens to the mother's house. The reason now we know, now it is scientifically proved, then mother requires rest and good food. So usually they come to their house when there is a first pregnancy. To mother's house, there she doesn't have to bother. She has to just take care of her, and after delivery take care of baby. So this is very, very important. But when it is a second baby, then she has to look after the first baby also, the other babies also. When many babies, then she has to do cooking, cleaning, all the work. So she has to have a universal self-care, and she has to resume her work also. So now look at the developmental self-care needs, that you have to find a new routine. So you have to get adjusted to that, and taking up the role of mother, re-establishing the role as a partner, and of course, you have to care your baby a lot. Then health self-care needs, it is dealing with pain and discomfort. After birth, everything is not easy. The episiotomy scar will, pain, the cesarean scar will pain, the breast will pain. So, they are very discomfortable many times. So you have to take care, dealing with the physical problems and pain due to breastfeeding and judging maternal infant illness. So we have support system, not only we as a professional or as in healthcare, but from the partner, from the family members and the community level. We have to support all our mothers. So ACOG opinion is that care team should have the name, number, everything of, the patient should have and the husband should have. Then the postpartum visit, as we say, whenever it is, emergency, patient can come, but we ask them after 15 days and after 6 weeks of, everything is fine, 6 weeks postpartum. Infant feeding, they require help. One take, there are lactational consultant, as I mentioned, they can take help of these people. Then reproductive life plan and the contraception, it has been decided that they desire the pregnancy, but still you have to talk to them. Don't plan immediately, at least 2 years. Therefore, we have to make them understand the use of contraception. Then the pregnancy complication already occurred. Now she has delivered. So we have to take care of this part like a PIH, then like, abruptio placentae, anemia, gestational diabetes, and we have to continue to take care. Then of course, some cardiac problems also can occur. So you have to really take care of the, especially now the women, the elderly mothers are getting pregnant, and therefore they may have some atherosclerotic type of cardiovascular disease. So they have to take care of that part also. And as I mentioned, mental health is very, very important. The mother have to be strong, and therefore we have to support her from all aspects. And there are postpartum problems like, stress, urinary incontinence. So you teach them pelvic floor exercises, and dyspareunia, you can ask them to use the water-based lubricant. And some women may have a chronic health condition throughout, which has to be taken care with frequent follow-up. So these are the ACOG opinion for the postpartum care plan. So now look at the mother involution of the uterus. After the delivery, myometrium, they contract and retracts, and it becomes a pelvic organ within 10 to 14 days. So, and the breastfeeding also causes release of the oxytocin, then the involution of the uterus is more faster compared to the top feeding. But however, if the involution does not occur or there is a bleeding episode, we have to remember the retained placenta. So the primary PPH, we really take care because patient is with us. But secondary PPH is excessive bleeding in the period from 24 hours to 12 weeks of postpartum. And secondary PPH occurs, there is a study, it occurs in 1% of women, and it may be continuously following PPH, but most common cause is retained placenta and sepsis. There was a study done, and it was reported that the patient had a maximum secondary PPH cases between 8 to 14 days, and it was followed by the spontaneous vaginal delivery, then by assisted vaginal delivery, and then by cesarean section. So this may be why in a spontaneous vaginal delivery there is more chances of secondary PPH, because they deliver spontaneously, and sometimes the care, whether the placenta is completely out or not, that is not taken care. Then secondly, in assisted vaginal delivery, as well as during cesarean, we are there. So maybe the reason is that the secondary PPH, more care is taken during this, assisted and cesarean section. So chances of retained placenta maneuvers are, good, and retained placenta are less. So that may be reason why in spontaneous vaginal delivery, we see more cases of secondary postpartum hemorrhage. So management, all of us, we know if it is due to retained placenta, one has to, take out that placenta as early as possible. And it is also associated with sepsis. So you have to consider the sepsis part also. And if it is only due to sepsis, then we have to take care accordingly. Then when the patient is bleeding, but there is no retained placenta, then you may use tamponade with balloon, or aggressive surgical option may be required as an internal iliac vessel ligation and maybe even hysterectomy. So we have to really take care of this secondary PPH. It has been reported that a postpartum infection by Alex et al. In 2014 that 1 in 10 women had at least one infection episode within the first 8-week postpartum. And primarily it was mastitis, which was 4.7%, UTI 3%, endometritis 2%, and wound infection 1.8%. And 3/4 of the women received treatment, and mastitis was the most common infection. So now look at the piperous sepsis. The second major cause of maternal mortality, that is 13.2% after PPH in India. It is the third most common cause of maternal death worldwide as a result of childbirth. WHO has reported piperous sepsis accounts for 15% of the 500,000 maternal deaths annually. In low and middle income countries, piperous sepsis infection are the sixth leading cause of disease burden in women during their reproductive years. Piperous sepsis can cause long-term health problems such as chronic pelvic disease and infertility in females. So we have to, once patient comes to you, or she comes, we have to give them instructions, such and such thing happens, please come to us immediately. So how the piperous sepsis mother can present, it is when it is defined as the infection of the genital tract occurring at any time, see, between the onset of rupture of membrane and labor up to 42 days postpartum, in which 2 or more of the following are present, that is fever, 101.3 or higher, pelvic pain, abnormal vaginal discharge, presence of pus, abnormal smell, false order of the discharge, delay in the rate of reduction of size of uterus. So out of these 2 or 3 are present, we have to consider this patient with a piperous sepsis, and you have to admit the patient, and you have to see more vital signs, you have to take the vital signs, and once, vital signs, then you have to send the investigation, CBC if possible, C-reactive protein, urine routine, microscopic culture sensitivity, blood culture sensitivity, and then of course the vaginal swab culture sensitivity. And then you have to start the broad spectrum antibiotic, higher antibiotic till the culture report comes. And of course, hydration and other supportive treatment. Because as it is, you have seen that the piperous sepsis causes 13.2% maternal mortality in middle and the low income group. So we have to really take care of this piperous sepsis. So now the lactation, status of the breastfeeding practice and child mortality in India. It has been reported with the NFHS for 2015 and 16 that 14.6% children were fed within 1 hour of the birth, and 54.9% children fed exclusively as a breastfeeding for first 6 months. So that is very, very good. The mortality indicator of the SRS is 2015 says the early neonatal mortality rate is 19 per 100,000 live birth. Neonatal mortality rate is 25 per 100,000 live birth. Infant mortality rate is 37 per 100,000 live birth. And under 5 mortality rate is 43 per 100,000 live birth. Now, of course, this is a 2015 survey, but now it has reduced a lot because our women are becoming educated, they are concerned, and of course, our health facilities are also having a advanced treatment, and now there are more and more institutional delivery. So these are the now if you consider the mortality, neonatal, perinatal, and the infant and the child mortality has reduced. So lactation is a maternal breast problem and condition may significantly have some difficulties during feeding. So these difficulties when mother says, because what happened, the baby keep on crying, and we keep on forcing mother that you are not breastfeeding the child properly. But there may be some problem during the breastfeeding. So it has to, if it is retracted nipple, we know. If it is some other problem, we know. But we have to really concern as an obstetrician and the lactational consult and the pediatrician that is there any problem with the child. So we know that what are the human milk advantages, that colostrum and the breastfeeding, we know. But when there is a preterm baby, when there are preterm babies, whether there are babies which require NICU admission, the breastfeeding becomes a problem. But still, we ask our mother to give, expel the breast milk. We can give with the rice tube, or we can give the bati spoon. But this is the best option. But sometimes, when the fetus, the baby is full term, still there are problems of the breastfeeding. As I mentioned, we have to take care on mother part also and baby part also. So we are the one who are going to diagnose why the infant, why the baby who is term baby is not breastfeeding. And all the time you don't say, baby is not feeding, so let her keep on feeding. But you have to take, baby should not become hypoglycemic, and you may have to start the stop feeding. And there are very few maternal infections which are contraindication to the breastfeeding. And therefore, one has to motivate, one has to counsel the pregnant woman during antenatal period and mother for the breastfeeding. Now look at the vaccines. That the vaccines, as we know, there is a change in the cellular immunity, and hence the pregnant women and the mother are more susceptible for the infection. And therefore, we start the vaccination during pregnancy. It not only protects the mother, but also protects the baby by transplacental transmission of these antibodies, giving the passive immunization in first few months of newborn life. And when the immunization of the baby occurs later on, then they become the active, immunized. So what happens? We give Tdap. Nowadays, we have shifted over to Tdap, and Tdap is a really good, it protects the baby. At the same time, influenza is also recommended, and hepatitis B, if the mother is not taken 3 doses previously, we can also recommend hepatitis B vaccine. Now, inactivated vaccine, hepatitis A, pneumococcal, meningococcal virus may be recommended. These inactivated vaccines are indicated if there is a high risk of infection by these agents. Yellow fever vaccine is recommended during pregnancy if she is traveling to that place or staying in that place, but the use in women breastfeeding babies under 6 months is contraindicated. Triple viral, HPV, chickenpox, and dengue vaccines are contraindicated during pregnancy. However, HPV vaccine should be, motivated. You should motivate your mother to take the HPV vaccine during puerperium if she has not taken. Then the vaccination for respiratory syncytial virus and group B streptococcus for the specific use in pregnant women are in still advanced stage of development. So COVID-19, we all of us are aware, not only the American College of Obstetrician and Gynecology, but Society of Maternal Fetal Medicine has recommended that pregnant individuals who meet criteria for receiving COVID-19 vaccine may choose to be vaccinated. Of course, Foxy was the first one during COVID-19. Then we started recommending government that we should vaccinate our women during pregnancy, whether in the first trimester, second trimester, third trimester, whenever she comes, we have to vaccinate, because it was we had put forward because many women died during COVID, and therefore it was decided even she in the preconception phase or whether she's pregnant or not pregnant, we should vaccinate our women with the COVID-19 vaccine. And the government guidelines also says the same thing. Now, the contraception, as we say that the contraception is very, very important. And, once she conceives, then she goes for abortion with the baby in her hand. And at the same time, she doesn't want to go for abortion. Then she is going to end up with the delivery, which is going to be complicated, not only to her, but also to the newborn, as well as the baby inside the uterus. So one has to really motivate them, counsel them for the contraception. So when contraception should be started? It is said 2 weeks after delivery, when especially mother is not breastfeeding. Or full breastfeeding, she should be initiated after 2 months. There are the false, things, myths are there that till you breastfeed, you will not conceive. But this myth you have to take out from our women's mind, mother mind, and they have to have a proper contraception during breastfeeding period. So what are the contraceptive options? Of course, lactation amenorrhea, as we said, is not, it doesn't cover much. Barrier methods also may fail. Combined oral contraceptives are contraindicated because it may interfere with the breastfeeding. So the progestin-only methods, and ACOG also has recommended mini pills then depot medroxyprogesterone, etc., subdermal implant, intrauterine device, surgical sterilization. These are the options available. And now, of course, we had done more the study about the PPIU study. That is also one of the best option for contraception. So I conclude, taking care of the 4th trimester is very important. Usually this trimester is taken for granted. Yes, patient is delivered now, she doesn't require any help. But mother, remember, mother has to take care of herself as well as newborn. Medical condition of mother and newborn require prompt diagnosis and early treatment to reduce maternal and perinatal morbidity and mortality. It is not only health professional, but also the partner, family, and community responsibilities to support mothers and babies for the smooth sailing of the 4th trimester, so we can have a healthy future generation. Thank you very much for the patient hearing.
Thank you.
Thank you, Dr. Madhuri. You go ahead, please. You go ahead.
Yes. Thank you, Madhuri Madam, for the excellent talk covering the 4th trimester, which is the most important period, but it is also the most neglected one also. All the pregnant females who deliver, they go a lot of physical as well as mental changes, and more so in the 4th trimester. And good care in this period is crucial for the health of the patient. And postpartum period, it includes the postpartum blues. The mother has lack of sleep. There is and all she's trying to adapt to the all sorts of changes. So it has to be an ongoing care, as you have said in your talk, that postpartum, it's an ongoing process. And so good care should be taken in this period. You have nicely elaborated on all the topics of covering all the aspects of contraception as well as vaccination. And really, it was an excellent talk. Thank you, madam. And I thank
you, Suyoga. Thank you,
madam.
Suyoga.
And
one point I would emphasize is that 4th trimester is in continuation with all the 3 trimesters. So we have to educate them. We have to promote breastfeeding and other aspects of the 4th trimester when they are coming in antenatal visits. So sensitizing them at that time really helps. How and the kangaroo care, the roaming in, all that, we have to sensitize them in the 2nd, 3rd trimester. Thank you.
And one more point which madam said, that lactation consultant should also be there in all the hospitals. That also is an important point, I think.
Thank you, Dr. Madhuri.
Thank you, Dr. Veera, Dr. Suyoga, Komal, Neeraj, and Apurba. Thank you very much. Thank you.
Thank you so much, respected Madhuri ma'am. It was such a eye-opener for all of us, and really breastfeeding, we know, and it's an Amrit. So we are celebrating Azadi Ka Amrit Mahotsav, so we should promote that. So thank you so much, ma'am, for your wonderful talk. And thank you so much, Chairperson, Veera ma'am and Suyoga ma'am, for wonderful chairing the session.
Thank you, sir.
Komal ma'am, thank you so much.
Thank you.
Thank you, Dr. Veera, Dr. Suyoga, and Dr. Madhuri madam. It was a very interesting session and such a real great talk, and a lot of discussions also happening. Thank you so much for joining in.
Thank you, madam.
Ma'am, with your permission, Komal ma'am and Niranjan sir, should we start our last and very interesting and exciting session of the panel discussion?
Yes.
So, can I have the CV? So, after this wonderful lectures, now it's the time to a very interesting session of the adnexal masses, which will be moderating by none other than but our very own Dr. Niranjan Chavan sir and Komal Chavan ma'am. So as we already introduced them, so it's the time to introduce our panelists. So the first, we have a very senior Dr. Vidya Thobbi ma'am. Ma'am is the professor and the head department of Obstetrics at Bijapur at Al Amin Medical College, Vijayapura. Ma'am is the past chairperson, Food, Drug and Medico Equipments Committee, Foxy 2018 to 20, National Corresponding Editor, Jogi, Organizing Chairperson, Kasoga 2016, Treasurer of the Kasoga, and a lots of credit in a lots of awards in her credits. So thank you so much. But ma'am is about to join. She is stuck in some emergency. So next we have the Manonmani Ramasamy ma'am. Ma'am is the professor and HOD. I'm extremely sorry if I spell wrongly, ma'am. Please give me pardon. And okay, thank you so much, ma'am. Ma'am is the professor and HOD Department of Obstetrics and Gynae, Coimbatore Medical College, and ma'am is the past vice president and at present the current president of Coimbatore Obstetrics and Gynae Society. Ma'am is the district director. I'm member of the district MTP committee, chief district obstetrician. Yeah, so thank you so much, ma'am, for joining and giving your precious time. Next, please. Next is a very dear senior of ours, Dr. Arun Madhav Barua, sir. Sir is the immediate past president of Dibrugarh OB Society and present the consultant Apollo Fertility, Guwahati, Assam. Sir is the chairperson of the Northeast ISAR, Northeast IAG. At present, the president the immediate past president of Dibrugarh, the senior vice president IMA of the Assam State Branch. Thank you so much, sir, for joining. Next, please. Dr. Nivedita Dutta, ma'am. Ma'am is from my own state, that Jharkhand, a very dear senior and Didi of mine. Ma'am is the president of the Bokaro Vijay Society, the consultant of K Memorial Hospital Research Private Institute, Bokaro, rising awareness and consultation in the rural area of Jharkhand, associated with a lot of NGOs and a supporter of the Foxy Manyata. Thank you so much, ma'am, for joining us. Second is very dear senior and a friend of mine, Dr. Darshan. Sir is at present the president of the Surat OB Society, consultant at Wadekar Hospital, fellowship in advanced ultrasound in Obstetrics from Mediscan, the past resident of the Nauroji Wadia Maternity Hospital, Mumbai, member of Foxy and a lot of other organizations. Thank you so much, sir, for coming and joining. Second is Dr. Rajesh, sir. Sir is a former associate professor, Department of OBG at Government Medical College, Latur, vice president and registrar of the College of Physician and Surgeon of Mumbai, that CIP of Mumbai, director, the endoscopic surgeon, Vaishnavi Hospital and Endoscopy Center, Latur, Maharashtra, postgraduate teacher at Vaishnavi Hospital. Thank you so much, sir, for joining and giving us the time. The second is the Dr. Shail Kaur, ma'am. Ma'am is the professor and in charge of the high risk antenatal unit at the Punjab Institute of Medical Sciences, Jalandhar, member of the Foxy
Dr.
Medical
Apurba,
Disorder
thank you.
Committee.
I think we can continue.
Thank you. Thank you so much, ma'am, for coming and joining. Dr. Susheela Gupta, ma'am. Ma'am is the director and senior consultant, obstetric and gynecologist at G&H Excel Medical Center, Salimar Bagh, New Delhi. Ma'am is a member of the Breast Committee, Foxy, advisor of the DGF, that is Delhi Gynae Forum North since 2018, chairperson Breast and Cervical Awareness Screening and Prevention Committee 2018 to 20, president of Delhi Gynae Forum North 2016 to 18, chairperson of the reproductive committee, chairperson of the adolescent committee of AOGD, and a lot of awards in her credit. So I think we finish all our introduction of the chairperson. Now hand over to our moderator, Niranjan sir and Komal ma'am, for the panel discussion. Over to you, ma'am.
Thank you, Apurba. And I think we are really honored by presence of luminaries as panelists. You know, we have from all over India, the experts in the field, Dr. Vidya Thobbi, Dr. Manonmani, Dr. Arun sir, Dr. Rajesh Darade, Dr. Nivedita, Dr. Darshan Wadekar, Dr. Shail Kaur, and Dr. Susheela Gupta. I welcome each one of you. And we are going to have a case-based discussion of panel discussion on the benign adnexal mass, and it is a case-based discussion. So I'll start with sharing my screen. Can you see my screen?
Yes.
Yes, ma'am.
I'll just make it slideshow from the custom. Sorry, from the beginning. Yeah. So now I have made it slideshow. So it is a very interesting, because ever since we do obstetrics and gynac, we are many times encountering this masses, adnexal masses. And at times, you know that they are most of the time benign. And we really have special situations with this benign masses, and we are in a dilemma how to go about. And that is actually the essence of this panel discussion with case-based discussion. So before I just start, I request your humble vote and support for the Vice President for the Foxy West Zone. And this is my humble appeal to each one. After working as the Chairperson of Medical Disorders in Pregnancy Committee and also winning the Merudara Hansotia Best Committee Award, I believe in coming together is a beginning, staying together is a progress, and working together is success. I want to work with all of you, and I make a humble appeal. Thank you so much. And now let's go to the topic. The term adnexa is derived from the Latin word adnectare, meaning appendage. Adnexa refers to the anatomical area adjacent to the uterus, and we know that it is formed with the fallopian tube, ovary, even the vessel, ligament, and connective tissue. So anything, wherever there is a mass, it is an interest to we obstetricians and gynecologists. So these are what we see in an ultrasound. I'm not going to go. These are kind of masses which we see commonly: the cyst, the corpus luteum, dermoid, cyst adenoma, endometrioma, leiomyoma, even hydrosalpinx. And even PCOD patients come with a mass, and we really don't know, and they are very scared when they come with an ultrasound that we have a mass, and they are going from doctor to doctor. And these are the causes of the acute abdomen. So now coming to the first case, we have this Mrs. XYZ. She's a 23-year-old primi gravida. She is pregnant, 11 weeks, and now she comes with pregnancy into her ANC clinic with acute pain in abdomen, sharp, non-radiating in the right iliac fossa, sudden onset, and it was not relieved by analgesic, accompanied with vomiting, 3 episodes since morning. There is no history of bleeding or any discharge, no history of diarrhea, constipation, fever, or any other problem. And patient has also conceived spontaneously. And when we examine her, we find the pulse 92, blood pressure is almost normal, everything looks okay. Per vaginum, the uterus is 10 week size, mobile, anteverted, soft to cystic, 8 by 8 centimeters. Right, a mass is felt in the right and the posterior fornix, and it is felt separately from the uterus, and the other fornix is free and non-tender. So, my now question, we have Dr. Darshan Wadekar. So definitely, I would just want him to describe about the ultrasound. Like definitely, we will go ahead for the ultrasound, and what is the thing which we actually see in ultrasound in an adnexal mass in pregnancy like this. Dr. Darshan? He's muted, Dr. Darshan Wadekar.
Yeah, Darshan sir. Darshan sir, you have to unmute yourself. I think sir is somewhere. Sir is there.
Okay, I think he must.
Okay, I will give you a call. Yeah.
Yeah, you give him a call. So now when we do an ultrasound, we see an enlarged edematous right ovary, cystic well circumscribed right adnexal mass. It's a large mass, 10 by 6 centimeters, and but reduced flow on color Doppler. So the USG is also showing a pregnancy 10.5 weeks, which is a normal. So my question to Dr. Manonmani, now seeing the ultrasound in the clinical picture, what impression do you have about this patient?
Yeah, as you already discussed, she is not having any features of normal DD of any urinary tract infection or any bowel disorders or any threatened abortion features. This could be a plain and simple, or it is a right adnexal mass with reduced flow, could be a torsion. So it might be a torsion with the intrauterine pregnancy. So you have to think of torsion OVD. Patient presenting with tachycardia and pain abdomen. So torsion, we have to go for it's better because she is only 10 weeks pregnancy. Any surgical intervention, you have to think of the anesthesia as well as route of approach. Whether it should be in a best hands, it would be a laparoscopy, and detorsion could be best. But it is a 10 centimeter. We need to look for other features also, either adhesions or
Yes, yes, definitely. Now the torsion is something which comes into our mind at a sudden when we see all this report. Dr. Nivedita, now this patient is pregnant. So you like to do any other investigation before we go about?
Since we are planning the treatment for the, if it's suspected torsion and planning some treatment, obviously we'd like to do some routine investigations and also to routine antenatal investigations, and also to exclude other causes of pain abdomen. So, I mean, you should think of an urine examination to exclude pyelonephritis, then a stool examination to exclude any OPCs. Then, if you have facilities, if you can do a if you think of surgical interventions, then you would go in for a laparoscopy to examine the torsion and see if you can unrotate the torsion.
Yes, I think everybody has pointed about towards laparoscopy, and so torsion of the ovarian cyst is which was evident on an ultrasound. Now my question to Dr. Rajesh. Yes, yes.
Yes, because this is most of the time this is because of the corpus luteum cyst, and sometimes it is very, very large. If we are puncturing the corpus luteum cyst, then we have to give the progesterone support because we have to salvage this pregnancy.
Yes,
this is very important.
Very, very important point, because we need not only focus on the cyst but the pregnancy as well. And take now coming to we are having all the luminaries in laparoscopy also. Dr. Darade is there, Dr. Arun sir is there. So, and many of you have pointed out laparoscopy is better. So now coming to Dr. Arun sir, what will be your approach, laparoscopy or laparotomy? Dr. Arun sir, Dr. Rajesh Darade.
Yeah, definitely. 100% will be actually taking this case up through laparoscopy. There is no point taking this for laparotomy because laparoscopy is available in every nook and part of the country. And it is always possible to detorsion the particular, if it is really true, you can even confirm your diagnosis and start doing a detorsion. If everything is fine, then I think the patient can go home after 24 to 36 hours. But having said so, sometimes different findings are observed. It could be even a corpus luteum hemorrhage or otherwise. So that's the time when it is very difficult whether to go ahead or just to remain quiet and come out without doing anything, because the cyst exists. Whether to do or not to do is a big question, and that should be a point of discussion today. That's what I feel. I think, Madam, cyst in this case, cyst is around 10 centimeter. So
Yes.
definitely I'll go for the enucleation of the cyst. And if necessary, I might fix the ovary on the lateral wall also, so that there will not be again twisting of the ovary in the future.
Yes, because the cyst is bigger here. And what will be the, what are the care which we will take? Because we need to know that if you are doing laparoscopy, are there any maternal or fetal implications for the procedure? Do we have, are there any guidelines for doing a laparoscopy in pregnancy?
Obviously, there are guidelines. We need to follow those guidelines very rigidly. The first important guideline is we should use minimum intraperitoneal insufflation pressure. The puncture points obviously has to be far away and it will be comfortable. And at no point of time we should try to manipulate the uterus until and unless it is absolutely necessary for the safety of the patients. Because the more manipulation we have, and that's the biggest advantage of performing a laparoscopy or laparotomy, because we can perform the surgery without manipulating the uterus at all. And my point is that if we are doing a cystectomy at the same time, depending upon us, I'll not be really happy to do the same time, because 11 weeks is a really risky period. We never know, something can go wrong as well. But our main job is to give relief to the patient. Detorsion itself may be sufficient. As per this is my personal opinion. Because if you're taking too much of time in doing a cystectomy, we might end up doing an ovarectomy also occasionally. Because in a forum like this, where we are passing on information to the juniors, I think what is ideal should only be discussed. But if it is simple, yes, anyone can go ahead and do the things. The
Yes,
minimum.
I would take the opinion of the panel. What about cystectomy or detorsion? What is the opinion?
I would agree with Dr. Arun, sir, and say that detorsion would be the preferred line of treatment here. And here also I would like to add on that since the 10 centimeter cyst, which means 100 millimeters, chances of being a corpus luteum hemorrhagicum is very rare. So the more chances of being a torsion of the ovarian cyst. So detorsion, a simple detorsion would itself solve the problem in this case.
Dr. Shail, you want to add?
No, I also agree. A detorsion is definitely necessary. And at this gestation, early out is a preferable approach as far as possible.
That's the most important. Since the pregnancy is already an important part, we have to give due importance to it as well.
So I think every thing was said about laparoscopy, but then when we are doing certain interventions, what precautions do we take? Because, laparoscopy now, this is in the first trimester. If we have a patient in the second or third trimester, what precautions do we take during laparoscopy? Dr. Susheela?
During this procedure, I think progesterone support is mandatory.
Yeah, and if we have somebody coming in the second trimester and we need to do a laparoscopy,
then obviously we are going in for tocolysis, and if required, then you think of antenatal corticosteroids. If she's Rh negative, then and if you suspect that they could, obviously, if it's a second and third trimester, there were chances that you might handle the uterus a bit. So then you should also think of an anti-D prophylaxis in an Rh negative.
Yes, the guidelines of laparoscopy in pregnancy are very clear that you need to even document the fetal heart sound. You need to give neuroprotection because there may be any preterm delivery anticipated, antenatal corticosteroids, anti-D if you feel that there is going to be a lot of hemorrhage, and that is really the guidelines which are seen. So I think we have moved. These are just a differential diagnosis which we had put in. I think we will go ahead with the second case. Dr. Niranjan Chavan.
Thank you so much, Komal. We go ahead with a 14-year-old girl who is unmarried and who comes with a chief complaint of a large abdominal mass. She had acute abdomen and backache for about 2 to 3 days. Her LMP, she had come about 11 years back. So basically, she had come Minak attend just 5 days back, and then she had bleeding for 5 days, changed 2 pads per day. Next slide. On examination, we found that 34 to 36 week size big mass in this girl, and it was quite mobile, cystic in consistency, non-tender, smooth surface. The lower margin could not be made out, and the upper border of the mass was 1 to 2 centimeters below the intercostal margin. The mass was extending towards both the flanks. Rectal examination also confirmed the same findings. There was no involvement of the rectal mucosa, no nodularity or induration felt. Next slide. So this is what is the patient having a big mass, you can see. Can we go to the next one? So how would you approach this case when you have a tumor markers? If you see the CA125, AFP, beta HCG, this all appears to be quite normal. And we did an ultrasound also. And further, the ultrasound showed that it is a large complex cystic lesion. The uterus seems to be normal. ET was 5 millimeters, and it gave that multiple thick septae were present, and it was extending from the pelvis to the epigastric region with multiple echoes. And the impression was mucinous cyst adenoma of the ovary. So you have a girl who is so small, thin, tiny, and just menak of 5 days old with such a big mass. So can we have the next slide? We did a CT scan to confirm, and it's great, to find out that the same findings were there of 18 by 15 into 11. And however, there was basically a mass effect on the lower ureter, with hydroureter both the sides of the proximal ureters and the hydronephrosis. And here also it said that this is the cyst adenoma of the benign etiology. These are her CT scan pictures. You can see on the right upper part. Next, Riya Singh. So In such cases, what is the role of tumor markers? I would request Dr. Darade to speak on that.
Tumor markers in such cases, we have already done, I think, CA 125 or done routinely, we do CA 125. If there is beta HCG, alpha fetoprotein, and the LDH levels. So sometimes germ cell tumor markers also can be, these all markers can be erased in that cases. But I think in this case, you have already done CA 125, all the tumor markers are normal.
Next slide. Yeah. So basically, it is very important to understand that this is a benign mass, but still you have to keep in the back of your mind that it could be a dysgerminoma or a germ cell tumor, which is also quite rare of the rare, but it is found in adolescent girls also. I want to ask this question to Arun sir. What is Roma test and what is its importance?
Yes. The Roma test actually today has not been given due importance because there are different classifications by which we can take up whether the case is an epithelial malignant ovarian tumor or a germ cell tumor. Because Roma test differentiates only with one test that is called human HE4, human epithelial antigen 4. That is the only component that we are not doing on a routine basis. But having said that, Roma to today has not really lived to the expectation of every gynecologist, but it has come up off and on whenever it is required. But it does help whenever you are doing an HE4 estimation. It helps to know whether your particular tumor is a benign one or a malignant one. That's the most important part. The score that has been defined from an algorithm really helps in counseling with the patient whether to go ahead with a gynecologist or with a gynecological oncologist for this particular treatment. That is the basic cut-off clarification point. But having said so, I'll always say the RCOG guidelines of B score and M score are also quite helpful in delineating the points and also in counseling. For the further things, yes, it will all depend upon the histopathology and others. I'm not sure whether everyone across the country really does this Roma test on a routine basis. I used to do it 15 years back when the test was first introduced in China and Taiwan. But today I'll confine myself only to HE4 because other markers gives me almost equal information with CT and MRI backup and a good ultrasonography. That is my take on Roma 4.
Okay, thank you. Can we go to the next slide? So basically, this is what is very important also to keep in mind if you are considering malignancy, but as such, it is not that much taken care of. What is IOTA classification? I would request one of the panelists who is there to take up this. Darshan Wadekar, are you there? Please join us. Or we can ask Shail Kaur.
Manonmani is there.
Manonmani,
It is the International Ovarian Tumor Analysis. It basically divides it into benign and malignant, depending upon 5 criteria. So you have on benign side, you have 5 criteria like unilocular size of any papillary mass inside, which has to be less than 7 millimeters. Then whether the color flow, if there is any echo, if there's echo, then you think of dermoids. So, and in malignancy, you will have a higher color flow, you will have multilocular, you will have solid masses, you will have greater than 110 millimeters tumor, multilocular, and if there is any papillary masses inside, it has to be more than 7 millimeters. So when you have these criteria, you divide it into benign, B1 to 5, malignant 1 to 5, and it gives you a very good idea of whether the mass you see on ultrasound is a benign tumor or a malignant tumor.
Yes, absolutely right. Can we go to the next slide? Now, how would you manage this case? Now, she's being a young girl and her mother is very anxious. She has a mass. They've gone all through this. All the tests are done. They are more favoring towards a benign case. So counseling is very important. And I would request one of the panelists to take up this case. How would you manage this case? Any one of you Can I ask to Shail Kaur?
Okay, so this patient would definitely need the surgery considering the size of her mass itself. And since she's an adolescent girl, although lots of literature do say that it as much as possible try to preserve any ovarian tissue, but I don't think we'll be able to find any separate ovarian tissue in such a large mass. And definitely the other ovary would need to be evaluated. A proper surgical staging would be required. But since it's mostly going to be a benign mass and we should be able to remove the tissue and block it, that would be definitely preferable.
So what would you prefer, madam, in a young girl, a laparoscopic surgery or a laparotomy? Of course, there will be a difference of opinion. We have got Dr. Rajesh Darade, Dr. Arun, who do laparoscopy.
Personally, since I am not that well versed and it is such a huge mass, I would personally prefer to go for a laparotomy in this patient.
Yeah.
And could I just put in a point here? It is recommended that if you put in a scope and a suction and under direct vision, suck out the mucus, the tumor becomes small. And then you can again continue, clean the laparoscope camera and then again do it laparoscopically. So you can remove a mucinous cyst adenoma laparoscopically, even a large one.
Yeah, but in this case, it is really going up till the epigastric region. So where is the space to put a laparoscope? I mean, it will
so
be
you put in the scope inside the tumor, and from the other end you put in the suction, and you do the suction. And after you reduce the size of the tumor, you take out the camera once again, clean it, and then try to do the cystectomy.
Yeah, but
this much mass up, going up to the zetisternum, maybe I would opt only for laparotomy. So the experts of laparoscopy should give the opinion on this.
I mean, madam, we don't know. We always take the ultrasound or a CT scan with a pinch of salt because it is very unlikely. Unfortunately, it could turn out to be some borderline tumor. It's not easy to just put a laparoscope inside an ovarian tumor and do a suctioning. So it would be recommended to at least go for an ovarian, laparotomy. That is what I would suggest. Of course, there will be a difference of opinion. A laparoscopic surgeon can say he can put a scope through the Palmer's point, deviate the whole ovary onto the one side on the right hand side and then go through the Palmer's point. Some people also do open Hassan's technique in such cases, or in pregnancy also we can do. But in a small girl with a large tumor going up till epigastric region, it would be better to do an exploratory laparotomy. And it's once you see that the glistening shining surface of the ovary is there, what I usually do is take a stitch at the ovarian surface with a linen, and then I'm ready with a knife, which is a stab knife, and we just poke the tumor and cut open and put a suction immediately inside.
Absolutely, and drain out the
linen. So the whole tumor gets deflated over a period of time, and you can see that the bottle is filled with the suction bottle is filled, say about 1.5 to 2 to 4 liters of mucinous cyst. And before that also, I would prefer to put mops around the incision, because this mucinous material, it's very sticky, and it's been recommended that there has to be no spillage. If it spills into the abdominal cavity or into the intestines, then they cause adhesions and plastering of the abdomen. So it would not be an ideal situation, to put a scope inside, but I would prefer to, keep mops around, and then you have, purse string suture being taken just over the surface of the anterior surface of the ovary, and then you suck out. Then there are multiple septae. You might have to, direct your suction cannula on either side, and you can see that the whole tumor absolutely comes out. So you don't need a very big paramedium incision. Just from the pubic symphysis, just 2 fingers above the pubic symphysis up till the umbilicus is enough. You do not need to extend it whole. If you are very sure that it is a benign ovarian tumor and the whole thing can be just pulled up, you can see that there is a stay suture being taken and a stab knife being done, and then we can remove this whole tumor in toto, and then we go ahead to do a cystectomy. As far as possible, we see to it that we conserve that part of the ovary. And then, of course, before you go to do any surgery, You should see the contralateral ovary and then decide and take a proper consent. So what are the different fertility preservation modalities? I would ask one of the panelists, I think Dr. I can see here Dr. Arun, Dr.
Yes.
Rajesh.
What I'd like to say is, as you rightly said, the route for this particular case would be based on your expertise and also your pre-operative diagnosis. The probable diagnosis would also go a long way in deciding the route of this surgery. That point that you're making. If there are any suspicion of malignancy, I think there is no role of going for a laparoscopy. We have to do a laparotomy only. Because just now, an hour back only, I was doing a similar case, which is 32 weeks size. Successfully, I could go ahead and complete the procedure by laparoscopy. But again, that will depend upon your individual expertise and also the facilities that you are working around, and also a pre-working diagnosis. Because this particular patient that I operated was a fertility preserving surgery. Patient wanted to preserve and also they're willing to go for pregnancy. So under those scenarios, I always feel laparoscopy would be a better choice provided your pre-operative diagnosis is benign.
Yes, next slide, please. Absolutely, I agree. You have to individualize. And these are the surgeries which is recommended. Seeing a worst to worst scenario of an ovarian cancer in a young girl, and they are very important to be, they want that fertility. They are very anxious. So you have all these surgeries which are there: conservative cancer surgery, ovarian transposition. They also, they are transposed up just below the liver or below the spleen, so that they are away from the radiotherapy. If it is a malignancy and you have some ovarian suppression chemotherapy causes, because of that, so you need to, give them ovarian suppression. And of course, some of these girls, there might be some adolescent girls who are really in 18 or 20 years, and they want to freeze their oocytes and ovarian tissue before going ahead to do, cancer surgery strategy. So cryopreservation is an option where you can go ahead. Next slide, please. So this is also one modality, ovarian transposition, where you just cut the ovarian ligament and in such a way that you lift up the ovary from the ovarian fossa, and then you pull it up and stitch it, as Dr. Rajesh Darade said, that you need to fix it to the anterior abdominal wall, or you need to fix it up at a higher level with a peritoneal incision. Next slide, please. This is a wonderful diagram I wanted to show you, that in cases of malignancy, though this case is a benign, but you have to see the worst to worst scenario. We're talking about benign adnexal masses, and I want to complete the, adolescent benign ovarian tumor. But this is also a very important surgery which you need to understand, in which you are dealing with an ovarian cancer in a young girl. Next. So thank you. I would like to hand over the mic now to Dr. Komal. Anybody like to say some comment? I heard some voice. Hello. Okay, so we move ahead now.
Yeah, we'll go ahead with the third case. Now she's a 30-year-old, married since 1 year, comes with complaints of amenorrhea since 2 months, acute lower abdomen pain, PV spotting since 2 days, urine pregnancy test is positive. The beta HCG, as you can see, is 5,300 milli-international units. And on examination, you find the pulse to be 78, blood pressure is normal, there is no pallor. Per abdomen, it is soft, no guarding, rigidity, but minimal tenderness is there. And on per vaginal examination, uterus is normal in size. Right adnexa, fullness present. Right fornical tenderness. Cervical movements are tender. Left fornix is normal. There is minimal spotting. So now my question is to Dr. Shail. These are the patients which are very common in our OPD. And when seeing the history, we know what is the diagnosis. So what is your next step?
Definitely, since her beta HCG is more than 5,000, it becomes a little matter of concern. But if she does have, first of all, of course, we have to confirm that it's an ectopic pregnancy, that whether it's ruptured or not ruptured, and the exact size. But you have to look for the presence of fetal node, yolk sac, and cardiac activity. But once these things are done, basically what we'd like to do is whether we can go in for a medical management or whether we would need to go for a surgical approach. That is what we need to decide.
Yes. So before we go to the management now, Dr. Darshan is there. I just want you to, because sometimes we get a report showing a query ectopic. Things are so sometimes not very clear, and we have to clinically correlate. So Dr. Darshan Wadekar, what are the signs actually in ultrasound which we should be seeing? Dr. Darshan, I think I saw him again.
No, ma'am. Ma'am, he is stuck in some emergencies.
Okay.
So he is
I saw
unable to
him
join.
owning his video. So I think most of the times anybody wants to take that ultrasound, because you know that ultrasound and query ectopic is the most common thing which we keep getting in the OPD. Dr. Susheela, Dr. Nivedita.
What you get in the ultrasound is sorry, I don't. What you get in the ultrasound is no gestational sac in the uterine cavity. Then in one of the adnexa, especially here in this woman, it will be in the right adnexa. In the right adnexa, you will get a mass which will, if you have a color flow around it, then you will have a ring of fire around the mass, which shows good neovascularization. And sometimes you might even get, if this is an unruptured one, sometimes you might even get a small yolk sac or a fetal pole. And sometimes I've even seen a cardiac flicker in that. So this is what, very rarely, you might get a hypoechoic mass in the uterine cavity. But then that hypoechoic mass in the uterine cavity does not have any color flow. And that is not a pregnancy. That is not a gestational sac.
Yes. So we need to be really very careful and need to diagnose, and we need to know whether it is an unruptured or a ruptured ectopic. That is a very important cornerstone for our management. So now coming to the medical management, Dr. Manonmani.
So this particular patient, if you take this case, she has beta is more than 5,300. And you said in ultrasound, there was a flickering of cardiac activity. So when it is there, when we are on the size of more than 5 centimeters, so it's better we go for a surgical management, because medical management with all this cardiac activity, it doesn't fit into the medical management scenario. So better go for surgical management before she ruptures, so that we can salvage the tube.
Yes. Yes. Somebody said.
And here, this patient, even though she's hemodynamically stable, but then considering beta SCG, considering this particular patient, beta
what
SCG
about the
and
role of methotrexate?
I know that her size is more than 3.5 and there is a cardiac flicker. So the chances of failure of methotrexate is going to be high. But I think the textbook is very clear about what the indications for methotrexate are. However, I have found that even with such cases, repeated dose of methotrexate does help in having a successful completion of an ectopic pregnancy. You might require 3 doses of methotrexate, but then sometimes they do work.
Dr. Arun, sir, your comment on this? Because we yes.
I was a little disconnected because of the network. I could guess that this is a question regarding methotrexate in ectopic pregnancy, right?
Yes, sir.
With the gestational sac 5 millimeter, and presence of a fetal pole.
And what would be the serum HCG level?
It is 5,300.
Definitely, I'd prefer to go for a methotrexate in this case, because that gives us a much better chance. Of course, again, as I always believe, the counseling plays a very important role to these patients. We can prevent a surgery always when you are giving methotrexate. My doses is 1 milligram per kg of body weight. And I used to give normally a single shot of methotrexate and review serum HCG after 72 hours. And if required, repeat dose after 5 days. But again, these patients may not be always successful, so they need to be under follow-up. And that is what most of the patients doesn't like to define, and that's why we end up with doing a surgery. But if you get a good patient who understands the protocol well, they really do good enough and they are successful in preserving their fallopian tubes, even with an ectopic pregnancy with methotrexate therapy.
Yes, so we need to really have a good patient selection when we are doing a medical and explain them that the follow-up is very important. The way the monitoring is there, the serial beta HCG which is going to happen is really very important. Now, definitely laparoscopy is in, but what would be it? A salpingectomy or salpingostomy? Dr. Rajesh Darade?
Fallopian tube, if the ectopic is a big one or ruptured and there is a really fallopian tube is damaged very badly, in that case only we can think of salpingectomy. Otherwise, if it's an unruptured tubal pregnancy, we can take a linear incision on the most prominent part of the fallopian tube and try to conserve the fallopian tube. Most of the time we have the hydrodissection. After taking the incision, we just do the hydrodissection and remove all the products of conception. And the most of the times if the hemostasis is achieved, then we can do the salpingostomy.
Could I ask a question? Could I ask a question here?
Yes,
My point is that after a salpingotomy, do you find an increase in the incidence of a repeat ectopic?
There are chances of ectopic because, but it depends upon the case, how it is. But there are always, you have to explain, you have to talk with the patient. By doing this conservative management, there are definitely, as compared to the normal fallopian tube, there are more chances of repeat ectopic on that side. So you have to sit with the patient and really discuss with the patient before going for this surgery.
So that is why, Dr. Komal, I prefer doing a salpingectomy because then in the repeat ectopic, she says that the first time also you've done something, now again you're doing a surgery. So, and then with the era of IVF coming up, and if suppose the tubes are damaged, then she always has a IVF to fall back on. And then there's a second tube which is there to salvage a next pregnancy. So I have really very little I've done very little of salpingostomy. That is why I was asking, sir, about what is the chance of repeat ectopic with that.
I actually agree with that. Once you counsel the patients that there's a risk of recurrence, most of them even do not opt for salpingostomy. They say if the other tube is fine, it's better to not have a recurrence of ectopic and go ahead. Please go ahead with the salpingectomy. That's what the usual response is in these patients.
Yes, I agree. If it's a very small or something, then it's always good because we really don't want the repeat ectopic in the same tube happening. And that is our primary concern because we really are worried about the future implications. So counseling here plays a very important role. Some patients are very skeptical. They just want the tube not to be, they want to retain the tubes, they feel or something. And those are the time where the counseling is very important, and the way we counsel, actually we can then offer the best treatment to the patient. So let's move to the fourth and the last case, Dr. Niranjan Chavan. Yeah. So this is the fourth case, and Dr. Niranjan Chavan. So this is I'll read the case.
Yeah, I'm sorry, Komal, I can do that. I was just on the phone. So she's a 26-year-old nulliparous woman, married for 3 years with complaints of inability to conceive. And as you can see, she's a case of infertility and has an acute pelvic pain for 1 day, sudden discomfort of, chronic abdominal pain, which is there, not sudden, chronic, and severe dysmenorrhea for 1 year. Her menstrual history is absolutely fine, but she has severe pain, which is unbearable. Can we have the next slide? So it gives an idea that something is related to endometriosis. And this is a ground glass appearance you find on an ultrasound, a typical endometrioma in the ovary. And this is what you find on a laparoscope, a big ovarian tumor which is there, and there is blood clotted inside, dark brownish color material inside. Next. So this commonly we find, it's a cystic mass about 6 to 7 centimeter per rectal, no palpable nodularity, and so obviously the diagnosis is made endometrioma. Can we have the next slide? So what is the classification of endometriosis, Doctor? Can I have your Manonmani, madam? And how will you manage
So
this?
now the latest AGL classification, it has got involved peritoneum, statutory guidelines, and have got different guidelines, and AGL is updated on 2021, which involves ureters. This is SRM guideline. So it's peritoneum, ovary, and all the lesions, depending upon the lesions, the scores are being given. So total points for the peritoneum comes to 30, and the stage 4, it is going to be more than 52, it is stage 4. And if the POD is obstructed, then the scores are more. So this is our ASRM guideline, but AAGL has come out with a recent guideline. It involves ureters, bladder, apart from ovary and tube, all the abdominal structures are also counted. So it has the both clinical as well as ultrasound appearance for the endometriosis status classification. So this is what we are doing. Yeah.
So basically, laparoscopy is the gold standard for the diagnostic modality, and at the same time, you need to do take a consent, for an operative laparoscopy. Once the patient is under anesthesia, and if you want to do an operation on her, you need to have that pre-op consent, a proper consent of, evacuating the blood contents which are there in the ovarian endometrioma, try to fulgurate or try to, see that you suck out all the endometrial fluid which is there, and also to cauterize the bleeding points at the base of the ovarian, endometrioma. So obviously, what would be the choice, a laparotomy or a laparoscopy? Without
laparoscopy.
Without, I think all the panelists will agree it's only laparoscopy, and laparoscopy, nothing else. And that is the best option. You need to just, cut the, make an incision. Does the video work? But basically, you need to cut this ovarian, fix it with a grasper, and go ahead with the surgery, cut open, evacuate, put some fluid inside, suck out all the material, and achieve hemostasis, and just leave it alone. And that is what you need to have. There are higher chances of recurrences, but you need to in endometriosis, the best surgery is the first surgery, and you have to give it the best, because if you leave some of them, then they have recurrent chances, and she needs to be put on, GnRH analogs or ovarian suppression, pseudo pregnancy, and then maybe after 2 or 3 cycles, she can go for further infertility management. If we have time, we can go to the next case, Dr. Komal, as you wish.
We'll just go quickly over this next case because it is a little practical case. So we have a 28-year-old multipara comes with the complaints of dull lower abdominal pains in 6 months, which is now acutely increased since 4 days, white foul-smelling pervaginal discharge with high-grade fever since 4 days, dyspareunia. The menstrual cycle is that way okay. The past cycles are painless. There is a history that she's getting these repeated infections in the past. And when examination at present, she is febrile. There is a pallor. The pulse, there is tachycardia, 108, BP is 90/60. And on an examination, there is tenderness. Dr. Niranjan, can you mute?
त्याच्यामध्ये ते मध्ये गॅप
Can you mute Dr. Niranjan Chavan?
ह्युमर इमेजेस असतात.
Yeah. So there is on per abdomen examination, there's tenderness in the left iliac fossa, and what we see is there is guarding, tender cystic mass of 16 weeks, almost 16 weeks arising from the pelvis, and on per speculum also you can see a cervical erosion. And this is the examination on the bimanual that you see the left fornix to be completely full, a large 10/8 centimeters marks palpable, phonisal tenderness, cervical movement tenderness, and mobility restricted. Now, Dr. Manonmani, now this question is to you. What is the diagnosis and how to go ahead?
She's having recurrent PID. So now it is acute exacerbation of the pelvic inflammatory disease. And then again, there is a 16 weeks mass, probably could be some pus collection and the POD or a pyosalpinx. So TO mass. So you have to go for investigations and give antibiotics. And if the persists more, then you have to evacuate, so drain and better relieve of the symptoms. So as you already put the investigation, it is she's of the sepsis and the urine routine cells are there. So all culture sensitivity, and then we should be having following guidelines. We should give the high spectrum, broad coverage antibiotics should be given.
Yes, definitely we know that is the infection, and now we will evaluate, we will do, because it is a mass, we will have to evaluate all aspects, whether it is infected mass or it is, the differential needs to be ruled out, and a proper ultrasound and abdomen pelvis is something required. And Doctor, now I can see actually Dr. Nivedita, her video was off all the time. I can actually see her now. So the diagnosis we have done, we know the causative. So this PID, like how do we actually differentiate and which choice of antibiotic is which? Because what happens is we are not able to know whether it is a tuberculosis first instance or whether it is what infection it is. So what will be your choice of antibiotics and how many days you will give antibiotics, whether you'll open, what will be your take? Dr. Nivedita.
See, the commonest infections are going to be either an ascending infection or gut infection. So the coverage which I usually give are the cephalosporins, especially the one with a slightly more gram-negative coverage, which covers E. coli, Klebsiella. So I would think of a ceftriaxone with aminoglycoside as well as metronidazole or clindamycin. So that covers bacterioids as well as the gram-negative coverage. And this antibiotic prophylaxis I give for 14 days, 14 to even 21 days. There are no shortcuts. There's nothing about 5 days or 7 days in this. You have to continue it for 14 to 21 days. So this is the antibiotic coverage for, if you think of it as an abscess or an acute PID. Now in an abscess, as an abscess everywhere, abscesses should be drained. Otherwise, it is going to be very painful. If this is an abscess and if you confirm that, okay, there is the look is like an abscess, ultrasound, sometimes if you have facilities for a CT scan very well diagnoses an abscess. And then even through the pouch of Douglas, you can go in and drain like we used to do colpotomy earlier. So we could do, we can go through the pouch of Douglas and drain the abscess. And otherwise you can put in a scope, see after antibiotic coverage, put in a scope, identify it, see that is an abscess, and then drain the abscess and continue with the antibiotics.
Yes, we need to actually go, the ultrasound guided also, we can drain it. That is very simple.
Absolutely.
It's a huge mass. And what about laparoscopy? You said about we can do laparoscopy.
One is for identification. When you do a laparoscope, put in a laparoscope, you see the mass, you see any other additions, and then you can differentiate, okay, whether it's a tubervarian abscess due to an infection or you suspect tuberculosis. Then if there is any fluid, you can even take out aspirate the fluid with a laparoscope and send the fluid for investigations for tuberculosis and cytology. And if abscess is present, as I said, you can even do a surgical evacuation of the abscess under laparoscopy.
Yes. So when we have an acute PID, we need to know that, as Dr. Nivedita rightly pointed out, we give a proper course of antibiotic. But if you feel that the patient is not responding to the medical line of treatment, or you suspect a rupture of the abscess, or you're a little uncertain about the diagnosis, the general condition of patient is not improving, that warrants a surgery, then that is a time when you can do any of these surgeries which we just discussed, the colpotomy or the percutaneous drainage or exploration. And then here also we need to really, because if we have a young patient in the reproductive age group, we need to be little bit conservative, and we need to concern about their fertility, even if you feel that the tubes are badly damaged, or then you see some tubes, but if you need to have a consent beforehand, explaining all the, because there may be adhesions. Like I had to open one case and the patient had a lot of adhesions, and all the ovaries, it was like a tumor organized, even with the ileum and the cecum, and it becomes very difficult to then go ahead to do some radical surgery if consents are taken. So I think that counseling is really very important at the start of the surgery when you know that the infection is very, very severe. So I think let's end with this quote: be less curious about people and more curious about ideas. This is by Marie Curie. And with that note, let's end the panel discussion. I think, thank you so much, all of you, for the wonderful discussion what we did. This is thanks from Dr. Komal and Dr. Niranjan Chavan. And thank you all the esteemed panelists who have joined here. And if you change the way you look at things, the things you look at change. And that is the reason we should open our eyes and we should really be more going all the differentials about the adnexal mass and give a better outcome to all our patients. Thank you so much. I will stop sharing. And if Dr. Apurva is there, he can go ahead with the vote of thanks.
Yes, ma'am. Yes, ma'am. After this wonderful and awesome discussion, adnexal mass is always like a confusion for all of us. What to do, what will be the, the mode of the treatment, what will be the mode of the operation, what will be the route of the operation. And I think this whole case-based discussion is really an eye-opener for all of us and for our audience. So thank you so much, Komal ma'am. Thank you so much, Niranjan sir. And thank you so much to all the wonderful and beautiful panelists for making this, panel discussion so lively and so vibrant. So the end can't be an end without, say, the vote of thanks. So with the permission from Komal ma'am, and should I go for? Okay.
Please.
So after this wonderful webinar, now it's the say to this is the time to say goodbye. And before that, the vote of thanks. So I would like to thank the power couple of the Foxy, our own Dr. Niranjan Chavan sir and Dr. Komal Chavan ma'am, who is the brainchild of this whole webinar. And without the dreams and without their effort, this can't see the day of a light. So thank you so much for organizing this webinar. And to our chief guest, Dr. P K Shah sir. Sir is always there for blessing and for bless us. So thank you so much, P K Shah sir, our guest of honor, very dynamic, Dr. Rishma Pai ma'am, our wonderful speakers, Dr. Murlidhar V. Pai sir, and our own Madhuri Patel ma'am, the gorgeous chairpersons, Dr. Ranjana Khanna ma'am, Dr. Vinita Singh ma'am, Dr. Veera Lohia ma'am, Dr. Suyoga Panat ma'am, for chairing the session so wonderfully. All the panelists, Dr. Vidya Thobbi ma'am, Dr. Manonmani Ramasamy ma'am, Dr. Arun Madhav Varwa sir, Dr. Nivedita ma'am, Dr. Darshan sir, Dr. Rajesh sir, Dr. Shail Kaur ma'am, Dr. Susheela Gupta ma'am, for making this webinar a grand and huge success. Thank you so much to everyone. And thank you so much. The last but not the least, our, the partner, the Sealed Connect, the Chitrakalaji, the Stalin is there, Nishant is there. Without their help, without their technical support, this can't be possible. So thank you so much to all the audience who are there to last day. Thank you so much. Thank you.
Thank you so much. Thank you for the opportunity.
Thank you, Apurva. Fantastic.
Thank you
Dr.
so much, ma'am,
Rajesh,
for
Dr.
the
Manonmani,
opportunity.
Dr. Shail, Dr. Nivedita. I think it was real great that everybody could join and we had a great discussion. Thank you so much.
And ma'am, from the